Thank you so much, ma'am. So I'll just make a very short presentation to give a very basic idea to our pathology residents here that what we are looking for in an MRI. So I'll just go full screen. Yeah. So let me start. So whenever we are talking about pediatric brain tumors or any brain tumors per se, the radiology is extremely important because radiology is a key to your diagnosis and your interpretation of pathology also. So basically in radiology, we look for two things: the anatomy, because especially for pediatric brain tumors, it is extremely important because your diagnosis changes a lot. In fact, you can predict some of the molecular or these diagnosis also depending upon the origin of the or site of or the location of the lesion. So what we look for is basically the location and the sublocation. So whether it's an infratentorial or a supratentorial tumor, it's a midline or off midline, whether it is arising from the parenchyma or whether it's ventricular or extraaxial. And finally, we look at if it's a supratentorial, then which lobe it is arising from, and then whether it's a gray matter lesion or a white matter lesion. So all these information is made available to you when you look at the radiological images. And finally, the margins and the signal characteristics in MRI, and these are also equally important because they give you an idea about a preliminary provisional diagnosis or a differential diagnosis of what kind of tumor you are actually looking at. So let us come to the first thing, that is the location. So what we do is, this is the MRI. So we acquire MRI in three planes. This is the axial plane. I'll just put a pointer. So this is an axial plane, this is the coronal, and this is the sagittal. We have to look at a lesion in all three planes because it gives us an idea about the three-dimensional anatomy of an lesion. And so, for example, we have to look whether it is in the supratentorial compartment, whether it's in the ventricle, whether it's midline, off midline, if this part is the supratentorial in the coronal section, the brainstem, or in the cerebellum. So we have to look at a lesion in all three planes to see what is the orientation of the lesion in relation to the anatomical structures of the brain. Another important thing which we should see in the sagittal section is the pituitary, and we will see some of the cases where we can see the lesions in these regions and how to interpret the lesions in these regions. So another important thing for you before you interpret any MRI is you have to remember it is opposite of what we see. So this is the right side in MRI and this is the left side, right? Next is the margins of a lesion. So margins of a lesion can be circumscribed and diffuse, and how do we interpret that? Look at this one, this image, we can see there is a lesion which is present in the basal ganglia. It's a very well-defined lesion. How do we say it is well-defined? Because the margin of the lesion could be very well delineated from the adjacent normal parenchyma. Whereas on the lesion on the right, where we see that the outline of the lesion is not very well clearly delineated from the adjacent normal parenchyma. So this is a diffuse lesion. And this is a very circumscribed lesion, and therefore, for example, if you're talking about gliomas only, there are circumscribed and diffuse gliomas. So this gives you an idea whether it's a circumscribed lesion or a diffuse lesion. Coming to the next slide. So the basic sequences that we have to acquire in an MRI are which are important for you to interpret when you are noting down differentials of a lesion, include these two. First is the T1 and a T2. Now remember, T1 is a basic anatomical sequence. How do we say that it is a T1 weighted sequence? So in T1, the gray matter which is on the outside is gray and the white matter is white. It is very easy to remember. Gray is gray and white is white in T1 weighted image, and the CSF appears black. The exact opposite of this is the T2 weighted image, in which the gray is white and the white is black. So basically the white matter appears a bit darker and the gray matter appears a bit brighter and the CSF appears bright. So these two are the exact opposite of each other. We should remember the T2 weighted image is an extremely important image, and this is the first image which we have to look for whenever we are trying to interpret the anatomy and as well as interpret any lesion. So for example, we are looking at, this is a normal MRI of infratentorial part of the brain where it is seen. So this is basically the fourth ventricle, the pons and the cerebellum. So these are two lesions. Both are midline lesions. Both are located within the fourth ventricle. However, if you observe carefully, this one appears a little bit bright. So whatever appears bright is called as hyperintense. Whatever appears dark is called as hypointense. And what is hyper and hyper as compared to? So we compare it with the signal intensity of the gray matter. So we have to compare the signal intensity of the lesion with the gray matter. So if it is brighter than the gray matter, we say it is hyperintense. If it is darker than the gray matter, we say it is hypointense. So basically, this gives us an idea about the cellularity, or if we can extend it to the grade of the tumor in some cases. So basically, the cellularity is very well depicted by this. So here we can say that this is generally a hypocellular tumor or a lower grade tumor, whereas this one is a higher grade tumor. Coming to the next section, so I'll be teaching about only 3 sequences which will be very important to you. First is the T2, second is a diffusion with an ADC. So what is DWI? DWI is a diffusion weighted imaging, and ADC is the corresponding image to that, which is called as a apparent diffusion coefficient. These two are always read together. And how do we identify this sequence? It's a very dirty looking sequence, so where you can't see the skull and everything appears not very clear to you. For as pathologists, you can remember this much only. So that is a diffusion weighted imaging, and these two images have to be seen together always. So in DWI, the CSF appears black. In ADC, the CSF appears white. And the rest of the parenchyma appears black in ADC, and rest of the parenchyma appears bright in DW. This is how you identify. Now, what do you mean by diffusion restriction? Diffusion restriction means the normal free flow of water is restricted, basically in tumors, generally due to the high cellularity of that tumor. So, diffusion indirectly gives you an idea about the grade of the tumors. There are other reasons of diffusion restriction also, but you to processly remember, the higher the diffusion restriction, generally the higher is the grade of the tumor. So, for example, we looked at the first tumor. We can see here that it is not bright in diffusion and it is not dark. So what we told was bright in DWI and dark in ADC means a higher grade, or that is called as diffusion restriction, which is non-restricting. Whereas the second one, it is showing bright signal on diffusion weighted imaging and dark signal on ADC. So therefore, this is diffusion restriction, and therefore this is likely again a higher cellularity tumor. The last slide, the third, that is the another very important thing that you should know, is a post-contrast. So the post-contrast sequence is generally done on a T1. How do we identify this is a T1? Because the gray is gray and the white is white. And how do we know this is post-contrast? Because we can see this white thing inside the vessels. So this is basically gadolinium-based contrast agent. And why do we give this? We give this to enhance the contrast or to see the tumor better. And it not only shows us the tumor better, it tells us that there is a loss of blood-brain barrier. So normal parenchyma of the brain does not enhance because the blood-brain barrier is intact, whereas abnormal tumor, which enhances because the blood-brain barrier is broken down. So depending upon the type of enhancement, also we get a lot of idea about what kind of tumor we are looking at. So the first tumor which we saw, it is showing intense homogeneous enhancement, whereas second tumor is showing heterogeneous, ill-defined enhancement or a patchy enhancement. So I would not correlate directly with the higher grade or lower grade depending upon the types of enhancement, but yes, it will give you an idea depending upon all this. So we look at the T2, we look at the diffusion, and then we look at the contrast. It will give you an idea about what kind of tumor you're looking at. So apart from this also, there are other advanced sequences like SWI, like perfusion and spectroscopy, which I'm not going into details of because it doesn't make sense in this particular class, but that also helps us to narrow down our differentials. But these basic sequences, if you remember, then it will help you in, first of all, locating the tumor and getting a basic idea of what kind of tumor you are looking at. So with that, I end my presentation and I hand over to Geeta Madam to start. Thank you.
Thank you very much, Katrin. That was a really nice overview to start off with. I know you're going to do another presentation at the end. So without any further, let me try and share my screen. Is my screen visible and full? Is the full screen?
Yes, ma'am.
All right. So today I'm going to be talking about pediatric brain tumors, particularly glial tumors. And before I go into that, I just want to get a sense from the participants about what you think, how frequent is brain tumor in a child by age group. So in the 0 to 14-year age group, Anamika, how frequent do you think brain tumors are in children? Are they rare? Are they frequent? just say something, doesn't matter. Ma'am, they are frequent. What about Buddhist? 15 to 39 age group, do you think it's very common?
No, there.
Huh?
I think
So,
it's rare.
yeah,
Rare.
you need to speak a little louder.
Okay.
So you feel that the 15 to 39 it's rare, and in the 40 plus, Shatabdi,
It is intermediate. Maybe.
intermediate. So you'll be surprised to see that in the pediatric 0 to 14-year group, it ranks as the most common brain tumor. It's followed only by leukemias. And in the 15 to 39, it ranks second. So I'm just showing you this for you to understand the importance of these tumors in young adults and children. That it's the second most common tumor in the 15 to 39, and it's lower down in terms of its frequency in adults. So, extremely important to know this that young children can 0 to 14 years, it is the most frequent tumor that occurs. Now, when we see a brain tumor, of course, the histology matters to us as pathologists, and more recently, immunohistochemistry and molecular alterations have also gotten important in making a diagnosis, not only for diagnosis but prognosis and treatment. But also important are, like Kajri said, the site of the tumor that affects what we consider as a diagnosis, the age of the patient, because different age groups have different tumors that are more likely to happen. The radiological picture, like Kajri showed you, that has a lot of information for us. And extremely important also are the operative findings. One thing I haven't mentioned is the duration of symptoms. So when one gets a biopsy, the factors that one has to think of even before putting the slide on the microscope is what is the age of the patient, what is the duration of symptoms, what is the site, how does the imaging look, and very important to communicate with the surgeons to know what they have seen. Okay, whether it's a vascular tumor, whether it was that sometimes they give you very little tissue, but you have to understand then that that's because it's in a eloquent area and they cannot biopsy more. Or if it's from the brainstem, they do a stereotactic biopsy, that is a guided biopsy, which is extremely small. But when you see it along with all this information, it helps you to make a diagnosis. And as we go along, you'll see why. So, going by sight, in the brain and spinal cord, overall, glial neoplasms are very frequent. When one encounters a tumor in the brainstem, again, it's glial neoplasms. In the temporal lobe, it's mainly low-grade tumors like the pleomorphic xanthosarcoma that Dr. Vami showed you, and the descendroplastic neuroepithelial tumor, which also she showed you in the last session, and the ganglioglioma. When one sees a tumor in the ventricle, there is no hard and fast rule that only these tumors occur, but these are the more frequent. You get what are the ependymomas and the neurocytomas. If the tumor is in the cerebellum, if it's high grade, one considers a medulloblastoma. Pilocytic astrocytomas and hemangioblastomas are cystic tumors with neural nodules, and these occur in the cerebellum. In the periventricular location, one often encounters lymphomas, and in the subependymal, that is just beneath the ependymal lining, there are two tumors, the subependymal giant cell astrocytoma and the subependymal. In the CP angle, do you know what tumors can occur in the cerebellopontine angle?
Medulloblastoma.
Can, but that's more frequently parenchymal within the medulla. In the CP angle, one sees from the nerves, schwannomas, meningiomas. These gliomas can also be seen there if they protrude out, but in that CP angle area, these are the tumors you see. And in the pineal region, pineal gland occurs is near the posterior part of the third ventricle. What can you see here?
Glioblastomas.
Yes, final tumors, but because it's in the midline, you can also see germ cell tumors. Remember that in the CNS, in the midline, one can see germ cell tumors like the germ cell tumors in the rest of the body. So when it comes to age group between adults and pediatric, it makes a difference. Young adults now, there is a lot of emphasis on tumors of young adults. And in the latest WHO, the pediatric type tumors have been separated out as low grade and high grade. It is not does not mean that these pediatric type tumors do not occur in adults, or the adult type tumors do not occur in children, but they're more frequent in the pediatric age group. So we'll go into this in greater detail later. Basically, the pediatric type gliomas, which are diffuse, are both divided into low and high grade. Now, just to get a sense of what are the tumors that are most common, I've used the CBITRIS data, which is the US data, and you can see this is a spectrum in children, and you can see that 40% of tumors in children, remember we said they're the most frequent tumor that you encounter in a child, 40% of them are gliomas. And amongst these gliomas, nearly 15%, someone's asking for approval to annotate. What do I do? Pooja?
Sorry, ma'am.
There's someone's requesting to annotate.
I'll just decline.
I can't.
Decline it, ma'am.
I can't seem to do it.
Decline. Decline it.
My pointer is on, so I'm not able to.
Okay. You'll have to turn off the pointer first. Right click.
Okay. So, I'll bring in the pointer option later. Yeah. Okay. So, if you see, pilocytic astrocytomas are fairly common in the young, in children. The other common tumor are the group of embryonal tumors, and that includes medulloblastoma, atypical teratoid rhabdoid tumor, and some other embryonal tumors. So, if you have an idea of this, in the brainstem, 60% of the high-grade gliomas are located in the brainstem. So, this is I'm trying to emphasize why you need to know site and age. So, when you compare in contrast to the adults, there's a big difference. We said that pilocytic was fairly frequent, whereas if you look at adults, pilocytic tumors are much less common. In fact, they seem to have more of a high grade tumor, glioblastoma, occurring in them. When you look at it by location, again, children tend to have tumors in the opticochiasmatic area, the suprasellar region, the cerebellum, the brainstem. In contrast, in adults, it's more in the lobar regions that you have tumors. In fact, if you look, the brainstem only has 3.6% of tumors occurring, cerebellum only 4.6%. So, just to emphasize the importance of knowing site and age of the patient. So, with that, we'll start with the first case. I think it goes to Anamika.
Yes, ma'am.
Yeah.
Case 1.
A 9-year-old male with a 5-month history of loss of vision.
Okay. So, Kajri,
Yes, ma'am. So basically, we are seeing only two sections. The one towards the right is your non-contrast T1, and one towards your left is a contrast T1. So we can see that this is, so first is the location of the tumor. It's most likely a midline tumor, though we need to see the entire sections, but most likely it's a midline tumor. The location of the tumor is an extraaxial tumor. It's a suprasellar lesion. So basically, this is the area, the one with the which is being pointed, that is the sella. So we can see that the sella is widened, and this is basically a suprasellar tumor. And obviously, the structures we are not able to see is the optic chiasma. So that is the opticochiasmatic area is not well seen in this particular image. And what we can see in the post-contrast, pre-contrast image and the post-contrast is it's an intense and homogeneously enhancing tumor. So from these two images, what we can see is it is a T1 hypointense tumor, which has a lobulated outline, and it is located in the suprasellar location. And it is an intense and homogeneously enhancing tumor. That much we can say.
Thanks. So this is a smear preparation, and can you describe what you see?
This one. This image seems to be a squash preparation, and this squash preparation show numerous astrocytic cells which are bipolar, having bipolar capillary wire-like cytoplasmic processes, and at some places we can see few eosinophilic thickened eosinophilic fibers. Mostly they are Rosenthal fibers now.
I don't think you're seeing that yet here, but here basically you can see that there's fairly uniform nuclei but long, and these hair-like long processes, which you correctly said are bipolar, or both poles have it. This is one of the sections I gave you.
Ma'am, in this image shows a biphasic pattern of the tumor.
Good.
One is the darker area and another one is the lighter area. Darker area, we can see the bundles of these bipolar, made up of that bipolar cells, that astrocytic cells, pyeloid cells. And the lighter areas are microcystic spaces, areas, showing microcystic areas.
Okay. So this is the what you're calling the lighter area, and the more loosely arranged, whereas the other is more compactly arranged.
Yes, ma'am.
So in the loose area, these structures that you're seeing,
Ma'am, eosinophilic granular bodies.
yes, these are just collections of glial material, and they form these globular outlines. Do you know what does it signify when you see them? Does
Ma'am,
it make
long
higher?
ma'am, these are long-standing glial changes.
Good.
This was degenerative changes are there.
So, do you know other tumors where you can see these?
Yes, ma'am. You can see it in glioganglioma and ganglioma also xanthoastrocytoma.
Yes. So you do see them in gangliogliomas and in pleomorphic xanthoastrocytomas, among some other tumors also which have it, which we'll discuss later. But that is definitely a clue that it is a long-standing low-grade tumor. And what about these kind of more elongated structure?
Ma'am, these more elongated structures are eosinophilic Rosenthal fibers.
Yes, Rosenthal fibers, which is just another morphological appearance of the same. And here we have some cystic change. And what is this area which is bordering this cyst?
Ma'am, these are the microvascular proliferation, like the cystic areas.
Yes.
At places we can see the glomeruli proliferation of the microvessels.
Good. So you're seeing this is quite characteristic of in pilocytic. Normally you think of microvascular proliferation as something that occurs in high-grade tumors, but in pilocytic astrocytomas, this garland-like glomeruloid proliferation is quite often seen. So I know you have the diagnosis already, and I've also let it out. You're thinking of a
Ma'am, pilocytic astrocytoma. Most probably it is the pilocytic astrocytoma.
good. So here, actually, we don't really need morphology. I mean, we don't need anything more to make this diagnosis. You can just make the diagnosis based on what you've seen, both on the smear and on the permanent sections. So in this suprasellar region, what are the other tumors that you can see?
In the suprasellar region, ma'am, pylomyxoid astrocytoma we can see.
Okay. Then any other not glial tumors? Anybody else? So it's when you have the pituitary and the Radke's pouch remnants, so you can see craniopharyngiomas. Okay. Also, because it's in the midline, one can see germ cell tumors in this region. Of course, there are many other tumors that can be seen there, including meningiomas and so on, but the frequently seen tumors, particularly in children, would be craniopharyngiomas and pilocytic astrocytomas. So, just a little bit about pediatric low-grade gliomas. Essentially, they, like I said, they're very common. They can occur anywhere in the neuraxis, but cerebellum is a very common site. Pilocytic astrocytoma is one of the most common low-grade gliomas, and this also includes the glioneuronal tumors. The MAP kinase pathway is the most common alteration seen in these tumors. And when you look at their distribution, this is a schematic of pediatric low-grade gliomas, including both the diffuse and the circumscribed. And you can see that in the posterior fossa, the most common tumor is this pilocytic astrocytoma. Even in the chiasmatic region, suprasellar region, it is one of the most common tumors. Whereas the other tumors like the ganglioglioma, the PXA and all are not seen here as often as when you have them in the lobar region. So just a idea of the frequency. So pilocytic astrocytomas in the WHO comes under the circumscribed astrocytic gliomas. And the circumscribed astrocytic gliomas include pilocytic, the high-grade astrocytoma with pyloid features, which is yet to be totally defined, pleomorphic xanthoastrocytoma, which you saw in the last session with Dr. Vani, subependymal giant cell astrocytoma, chordoid glioma, and astroblastoma, MN1 altered. So we'll just focus only on the pilocytic in the interest of time. Often they are cystic masses with a mural nodule, and in this particular case, it was more of a brilliantly enhancing opticochiasmatic mass. So you saw these pyloid or hair-like processes on the smear. Sometimes you're lucky and you get to see Rosenthal fibers and eosinophilic granular bodies also on the smear. Typically, it has this biphasic pattern of loose and compact areas. So here you can see the microcystic loose areas and the more compact areas. And the compact areas tend to have these Rosenthal fibers. And you can also see these eosinophilic granular bodies. These imply that it's a low-grade, long-standing tumor. The loose areas don't really have that pyloid appearance, and they just show a fibrillary matrix with very monomorphic cells. And here again you can see the two areas, the compact fascicular with the Rosenthal fibers and the loose reticular with the eosinophilic granular bodies. This glomeruloid vasculature, like I told you, is typical, and this is a higher part to show you how these vessels form almost like glomerular structures. Now, one thing that you have to bear in mind is sometimes you see a degree of pleomorphism. Now, when you see pleomorphism, Anamika, do you have to worry about it in a pilocytic?
It can be there, but as it is a low grade, we put in a low grade.
What do you mean by that? What is it when you see this kind of pleomorphism? See, you're seeing multinucleate forms here. It's called degenerate atypia. They say it's a pennies on a plate appearance, like coins arranged in a plate. So you're seeing these giant cells. Remember that if you see those in the background of other typical features of an astrocytoma, pilocytic astrocytoma with the Rosenthal fibers and the eosinophilic granular bodies, it is not a higher grade tumor but just degenerate nuclear atypia. So here again you can see this numerous nuclei forming a multinucleate cell, and this is called pennies on a plate appearance. Okay. So here again another, see, when you look at this on LOPA, you think, oh, do I have a high grade tumor that I'm dealing with? But you have the imaging, you have the information on that it's a child, you don't see mitotic activity, you see these Rosenthal fibers, and then you can literally ignore these bizarre forms. Now, if you have a doubt, one way to do it is to do a proliferation index like MIP1, and you'll see that it's very low if it's a low grade tumor. Suppose you really have a doubt about it, you can do that. Now, another feature of pilocytic is that it frequently involves the leptomeninges, and then in which case you'll see some amount of stromal desmoplasia or a stromal reaction to the tumor in the leptomeninges. Now, I wanted to bring in a word of caution. This is from a suprasellar region, another case where you're seeing what are these again, Anamika, these structures?
Pardon, ma'am?
You can't see my pointer, sorry. One second. Yeah, these structures here.
Ma'am, these are Rosenthal fibers, elongated closer.
Good. Yeah. Yes, they are Rosenthal fibers. Now, child suprasellar region Rosenthal fibers. You should not jump to a conclusion of pilocytic if the imaging features are showing not only that it's a cystic tumor, but that the surgeon tells you that he or she has seen machine oil like fluid coming out of the cyst. When that information is given to you, that's why I say you need to know what they saw intraoperatively. You have to think of a craniopharyngioma. And what happens in a craniopharyngioma? This is the tumor, the craniopharyngioma. The surrounding nervous tissue undergoes reactive gliosis, and that can produce these Rosenthal fibers, and that is called pyloid gliosis. And one has to be very cautious of this in cystic tumors, where you can see this again, the craniopharyngioma, and you're seeing so much. So if you got a section or a representative biopsy only from this area, you could jump to the conclusion that it is a pilocytic astrocytoma, unless you have the rest of the information and they have submitted all these epithelial portions of the tissue to you. Sometimes when it's a cyst with a nodule, the surgeon may not get the nodule and may only get the cyst wall, and the cyst wall may only show you this pyloid gliosis. And that is why it's important then to know the other features, other information regarding the case. So this can happen not only in the suprasellar region, you can see this happening in the spinal cord and in the cerebellum, where you have this hemangioblastoma, which mainly occurs in adults. Again, it's a cystic tumor with a mural nodule. If they haven't hit the mural nodule, the wall of the cyst may just show you pyloid gliosis. And like I told you, cerebellum is a very common site for pilocytic astrocytoma. So you shouldn't then, you have to base it on the age. The pre-op, if they felt that it was going to be a hemangioblastoma, you need to be sure: is this tissue representative of the nodule that was seen on imaging? Is that clear?
Yes.
So another feature that I want you to be aware of is, while typically these tumors are biphasic, sometimes you just see sheaths of neoplastic cells like this, and often you can see almost like an what appearance is this?
Oligodendron.
Yeah, almost like an oligodendroglial appearance, and sometimes you see these palisades of tumor cells. Now, all these make you wonder, is this a pilocytic astrocytoma? It's occurring in the cerebellum, and particularly in the cerebellum, quite often you only see this kind of a diffuse appearance without that biphasic pattern. And in that situation, we sometimes resort to immunohistochemistry. Now, which markers would you do to prove, or not prove, but at least help you to make a diagnosis?
Ma'am, first of all, we will I see this GFAP, glial acidic fibrillary protein.
Glial fibrillary acidic protein tells you it's a glial tumor. Now,
Glial tumor.
in the interest of economy and saving the patient money, here you're very sure it's a glial tumor, right? Almost 100% sure. So you don't really need to do a GFAP in this case. Anything else you would do?
Ma'am, ATRX surrogate marker that we can go for.
That is in diffuse astrocytomas, it's lost. In pilocytic astrocytomas, it doesn't really help. Two markers that more recently people talk of as helping are the transcription factor SOX10 and P16, and these are positive in pilocytic astrocytomas. So that together with that appearance makes one think of a pilocytic. I'm just telling you in the situation where it's not typical. Otherwise, you don't need to do any immuno at all. You can just make a diagnosis on the histology. So, talking of, since molecular alterations are of great importance, like Dr. Vani told you all in the previous session about how much we have moved towards molecular, it's important to know that in pilocytic astrocytomas, the most frequent alteration is the KII BRAF fusion at 1549, and that occurs mainly in the posterior fossa tumors. It also occurs in the pilocytic astrocytomas at other locations as the most frequent alteration. So, this is a KIA 1549 BRAF. You can also have other BRAF fusions associated with with KIA in pilocytic astrocytomas. But if you don't see the fusion, it does not mean that it's not a pilocytic astrocytoma, because like I said here, there are other alterations that can be present in pilocytic astrocytomas. So to summarize, these can occur anywhere in the neuraxis, and most common sites being the opticochiasmatic and cerebellum. They're well circumscribed, generally, cystic masses, and they have a biphasic pattern. Typically, Rosenthal fibers and eosinophilic granular bodies, glomeruloid vascular proliferation. These are the markers that would be positive in them. When in doubt, one can use some of these. More than 70% of them have this BRAF fusion, and there are other MAP kinase alterations which could be seen in other tumors, and it's a slow growing tumor. Therefore, it's a CNS grade 1 tumor. There are subtypes which are described. You mentioned the pylomyxoid. This is generally seen in infancy. It's in the hypothalamic chiasmatic region. It has the same pyloid processes, but it's set in a myxoid, a bluish background. You do not see Rosenthal fibers and eosinophilic granular bodies in it. Sometimes pilocytic astrocytomas may have a pylomyxoid focus in them. The importance of them is that they are supposed to have a poorer prognosis, but they have not been graded differently. So, in the WHO, the essential criterion, one of the tumors that does not really require molecular testing for diagnosis, is that it has got classic features with biphasic components and low proliferative activity with or without Rosenthal fibers. So, our case fits in with this classic pilocytic astrocytoma. You could also, if you see a low-grade tumor with the MAP kinase alterations, make a diagnosis of pilocytic astrocytoma. And in pylomyxoid, you do not see Rosenthal fibers, you see this myxoid background. So, if one is to make an integrated diagnosis on this, Anamika, I hope you attend with Dr. Vani's session.
Yes.
The histopathological classification, it would be what?
Histopathological classification, it will be other astrocytic tumors, pilocytic astrocytic.
Yeah, it would be a astrocytic tumor, right?
Tumor.
You have to say it's an astro. CNS grade is?
Grade 1.
1. Molecular information in our case?
Molecular information, ma'am, you can go for ma'am.
No. Anamika, what I'm trying to say to you is in our particular case, did I give you molecular information?
Ma'am, this is a classic picture, so we can skip it.
I did not do it, so it was not performed. So, what would be your integrated diagnosis? Given that the essential criteria is histology, what would be your integrated full diagnosis?
Pilocytic astrocytoma will be the WHO grade 1.
Yeah, CNS WHO grade 1. So the whole diagnosis would be pilocytic astrocytoma CNS WHO grade 1. Good, very good. So with that we finished the first case. I can see Anamika heaving a sigh of relief. Thank you, you did well. So we go on to the second case. This is going to Anvisha. All right. So Anvisha, you said that you have seen very few brain tumors in the past. So let's see whether you can at least broadly get some idea on this case. Okay. So, can you see the screen?
Yes, ma'am.
Please read it.
15 years male patient with generalized tonic-clonic seizure for the past 9 years.
Okay. So, Kajri, shall I just...
Whatever, ma'am, I'll describe this.
Yes.
So basically, we are seeing two images. The one on the left side is an axial T2 weighted image, and we can see the pathology which is marked with a red arrow. The one on the right side is a post contrast T1 weighted image. How do we identify? Again, I told in white, in T1, gray is gray and white is white. So basically, in the T2 weighted image, what we see is there is a lesion in the medial temporal lobe, medial and the anterior part of the temporal lobe on the left side, which is a little bit heterogeneous. It's not well defined, so I'd say it's a diffuse type of lesion. And in the post-contrast imaging, what we can see is there is no obvious post-contrast enhancement. So this much we can see.
Okay. So, Anvisha?
Here we see a HNE stem section showing diffusely infiltrating a neoplastic oligodendrocyte.
At this power, what can you really can't see that they are
Moderate cellularity.
Yeah, I would say mild, very mild increase in cellularity. Okay, a moderate would be much more. You're seeing more of this pink background, and it's actually it's the cerebral cortex with the tumor just going into it. So you're seeing just a mild increase in cellularity, but here it's moderate. I agree. Yeah, describe this.
Here we see round to oval cell with round nucleus with perinuclear halo in a eosinophilic glial stromal glial background with some delicately thin blood vessels.
Okay. The pericardial halos you're seeing more at high power, right? Over here.
Some
Sorry? Yeah. And these here are some entrapped neurons. So this is another high power view. Sorry, someone's again asking to annotate. I just take my pointer.
I'm sorry, Dr. Geeta, this is
perineural microcalcification.
Sorry. 1 second, Anvisha. So here you are seeing the tumor cells that you described, and these here are neurons, okay, which are normally in the cortex. Can you see some cells are present here as well? What is this phenomenon called, do you know?
Perineural satellitis.
Yeah, perineuronal satellitis. Good. And here you're seeing
Microcalcification.
lots of calcification. I provided this OLIG2, which you learnt in the previous session, is a transcription factor. And what are you seeing here? It's positive?
Cells are positive for OLIG2.
Okay. And ATRX?
ATRX also positive.
Yeah, so ATRX is interpreted as either retained expression or loss of expression. So here you would say it is retained expression. So now, how is your mind working on this case? What would you like to do next? You want to do IDH. Okay. This at this point, we have a 15-year-old with a how many year history of seizures? 9-year history. So that means from the age of 6, this child has had seizures, right? So it's fairly long standing, and you said you saw a oligo-like morphology, and you want to do an IDH because you're thinking of a
oligodendron.
Yeah, but an oligodendroglioma generally would not have such a long standing history. Okay, it would be a shorter history duration of symptoms. So here actually that's why with that age group and the the long duration, one has to think of those low-grade tumors that occur with epilepsy. All right. So you wanted to do an IDH. I'll tell you that the IDH is negative. So this is the crucial factor here. 9-year history of seizures. And these are some more images to show you the surface of the brain and just a mild increase in cellularity. It's diffuse. It's going into the cortex. Here, a little bit more moderate cellularity. Like you rightly pointed out, there are these thin-walled vascular channels and a very oligo-like appearance in monomorphic cells, monomorphic nuclei, diffusely dispersed with some clearing of the perinuclear zone, very much like what you expect to see in an oligo-like tumor. So you have OLIG2 positive. Therefore, what does that imply? That it is likely to be a glial tumor, correct? Anvisha?
Yes, ma'am.
Yes. Now, ATRX is retained, but IDH is negative. So now, do you think you want to do something else?
If we show a 1p19q co-deletion.
Okay, so you are still thinking of an oligodendroglioma, and you actually ideally then should be doing a PCR for IDH to look for the mutation and a 1p19q for oligo. But we are not going there because that's an adult type diffuse glioma, which was dealt with in the last session. We are looking at pediatric type tumors. So do you think there are other, remember this very, morphology of cells, that particular morphology, an oligo-like cell, may be seen in many other tumors. It need not be an oligodendroglioma alone. Okay, you can see an oligo-like appearance in neurocytomas, which are tumors of the ventricle. You can see an oligo-like appearance even in other tumors like in ependymoma or diffuse glioneuronal tumors, DNETs, decembroplastic neuroepithelial tumors. All these can have oligo-like appearance. So this particular tumor, I think it may be difficult for you to come to. Here, this particular marker that we've done, given the history and given the oligo-like appearance, we did a CD34. And CD34 is showing positivity both within the tumor and in the adjoining nervous tissue. Now, does this give you an idea, or shall I just proceed? Don't worry about it. It's a newly described entity. It's, we ourselves are becoming more aware of it only now. So it's perfectly all right that you have not thought of this tumor. But this one is what's called polymorphous low-grade neuroepithelial tumor of the young. And since it's a very long name, it's called plenty in short form. Right? Now, these tumors are grade 1 tumors. They are seen in with a long-standing history of seizures in young individuals. They have a diffuse growth pattern. They have an oligodendroglioma-like appearance. They definitely show calcification, lots of it, and they are positive for CD34. So the clues are this long-standing epilepsy, young adult or young children, median age is 16 years, our patient was 15, usually in a cortical location. This is another case which I had got from Dr. Vani, where you can see the tumor in the cortex. Here again, a diffuse growth pattern, and in her particular case, apart from this oligo-like appearance, there were other areas which had pleomorphic cells with and some spindle-shaped cells as well. So when you see a tumor like this, and you see a lot of calcification, there's no mitosis, there's a long-standing history of seizures, one has to think of this entity called plenty. It's CD34 positivity in the tumor, and the adjoining area also shows CD34 positivity. They are IDH negative, ATRX is retained. This is the cerebral cortex showing the CD34 positivity. and this is OLIG2 positive. Now these tumors are BRAF V600E positive by immunohistochemistry and molecular testing. We did not do this. We did not do a BRAF in our particular case. They have low proliferation indices. So most frequent is the MAP kinase alteration of BRAF V600E. It could also have a FGFR fusion. And the good thing about it is that it's got a, if you remove the tumor, they have a good seizure-free outcome in these patients. So it's important because there's a big difference in prognosis between a tumor like this and an oligodendroglioma. So essential criteria for this in the WHO is a diffuse growth pattern, oligodendroglioma-like component, if at all, very few mitosis. The CD34 is characteristic both in the tumor cells and in the adjoining cortex. IDH is wild type. It's an essential criterion that you have to prove that it's IDH wild type, which means if it's IHC negative, one needs to then do PCR. And there has to be expression of BRAF V600E either on immunohistochemistry or molecular evidence of a MAP kinase pathway alteration. All these are essential criteria. So without having all these, one cannot make a very definitive diagnosis. So now, going into looking at it as an integrated diagnosis, at a histological level, we can say it's a polymorphous low-grade neuroepithelial tumor. What grade did I say it would fall into? Anvesha?
Grade 2, ma'am.
It's a grade 1 tumor. Okay? But here, the molecular information we did not do in this. So diagnosis in this. Someone else wants to volunteer?
Polymorph.
Grade 1 polymorphous low-grade neuroepithelial tumors of the young.
And yes, and then what will be your grading?
Grade 1.
Okay. Would you say NOS or not?
We will say NOS
Why?
because it's not specified.
No,
We have not done the molecular.
exactly. We have not done the molecular workup, which is essential criterion for diagnosis, and therefore we have to call it a NOS. And in that situation, it does not become a CNS grade, but just a histological grade of 1. This is what Dr. Vani told you all at her session, and so this I want to emphasize this. NOS comes in when you have not performed the molecular test that is essential for making the diagnosis. NEC or not elsewhere classified comes in when you have done the molecular test, but they do not fit in with what is typically described. So in this situation, you use NOS for this particular tumor. So a little bit about pediatric type gliomas. This comes under the diffuse group of tumors. Most often have MAP kinase pathway alterations, particularly in the low grade. This shows you that pediatric type tumors can occur in adults and adult type tumors can occur in children. So there is no hard and fast, but the frequency is different. So you see less often you see adult type tumors in children and less often you see pediatric type tumors in adults. So just let's focus only on the low grade. The 4 low-grade tumors that are described are the diffuse astrocytoma, MYB or MYB1 altered, the angiocentric glioma, the splenty, and the diffuse low-grade glioma, MAP kinase pathway altered. So why were they separated out? Because they have, in the past, I'm sure that I myself would have called these tumors oligodendrogliomas in a child. But now we know differently. And it is because they have different molecular characteristics, they have different clinical outcomes, and a lot more has been done to study these to know that they are a completely different tumor. So they have a much lower progression rate, and they do not show the alterations that are seen in, oh gosh, someone else wants annotation. Sorry, 1 second. Yeah, do not see the alterations that you see in adult tumors, and they have an indolent behavior. And compared to circumscribed gliomas, we said circumscribed gliomas are the pilocytic astrocytomas and so on. These have diffuse gliomas have a higher recurrence rate. So when you look at the prevalence of this, if you again looking at these low grade gliomas, the diffuse gliomas are not very frequent, but they are seen. This light blue sector shows you what the frequency of these low-grade diffuse gliomas are. It's different from circumscribed in that they're diffusely infiltrating into the parenchyma. And more than 50% of them occur in the hemispheres. And the rest occur in other parts of the brain, like the hypothalamus and the brainstem and so on. And this I've shown before in a previous talk. The diffuse, like I said, is that the tumor cells diffusely go into the brain parenchyma. So here you're seeing what is called subpile. This is the pia, subpile satellitosis. Anvesha talked about this perineuronal satellitosis. Yes, I think in the last class, Vani had shown perivascular satellitosis, and that's the tumor cells sticking to areas, to certain parts or congregating in those areas when they diffusely infiltrate. So these are the four pediatric type diffuse low-grade gliomas: plenty, angiocentric, the diffuse astrocytoma MYB or MYB-L1 altered, and the MAP kinase pathway altered. So the angiocentric glioma is also a CNS grade 1 tumor. They have these bipolar cells. Angiocentric means they are located in a perivascular space, and most often they show this alteration of MYB to QKI fusion. Again, long-standing history of seizures occur in children and young adults. And here's a child who had focal motor seizures from the age of 2 years, just a 4-year-old child with a tumor in the temporal lobe and thalamic region. And here you can see the diffuse nature. These tumor cells are migrating all the way up to the surface, right up to the subpile region. You're seeing it mainly around vessels, and in this along here you can see this angiocentric pattern. Can you appreciate this very radial arrangement around vessels like a sleeve? Again here, and they are bipolar monomorphic cells which are seen within the parenchyma. So here you don't see mitosis, you don't see microvascular proliferation and necrosis. It's around the vessel, so therefore the name angiocentric. And classically, they show dot-like positivity for epithelial membrane antigen. There's another tumor where you see dot-like positivity. Do you know which one that is? For EMA? We'll come to it later. So here you see this dot-like positive because it's a glial tumor, you get GFAP positive. These tumors are OLIC2 negative. Unlike the other tumor that is OLIC2 positive, these are OLIC2 negative. And they often show this MYB QKI gene fusion. So essential criterion here is, again, you don't need molecular, diffuse growth pattern with focal angiocentric, and immunophenotypically evidence of astrocytic or ependymal differentiation. If this is present, you can make a definitive diagnosis based on the history. The diffuse astrocytoma MYB-L1 altered is also a CNS grade 1 tumor. Again, in drug-resistant epilepsy, again a diffuse low-grade glioma, very monomorphic diffuse pattern of infiltration of tumor cells. They have retained ATRX. They are another set of tumors that are OLIC2 negative, and this requires this demonstration of the MYB or MYB-L1 fusion to make a diagnosis. There is a surrogate marker with a protein available which can be seen as a nuclear accumulation, and important to diagnose because they have a good prognosis. So in this particular entity, amongst the diffuse gliomas, one definitely needs to prove that there is no IDH mutation, there is no H3 mutation, and there is an alteration in MYB or MYB-L1. So if one sees a low-grade glioma or astrocytic tumor in a child with a diffuse pattern, it doesn't fit with the other two, it's OLIC2 negative, one has to consider this, but without these, you just be at a NOS level with the diagnosis. And the last one, the MAP kinase altered, is again a tumor which has a diffuse pattern, could look like an astro or an oligodendroglioma, but you diagnose it only by the MAP kinase pathway alteration. So again, long-standing history of seizures, either an oligo or an astrocytic pattern. These are OLIG2 positive, and you have to demonstrate that they are wild type for IDH, wild type for H3, no deletions present for 1p19q, and they are MAP kinase pathway altered. So in this tumor, one definitely needs demonstration of these molecular changes and absence of CDKN2A deletions to make a diagnosis of this tumor. Otherwise, it remains a low-grade. If I have a low-grade tumor like this, if I'm not doing any of this, I would just say pediatric type diffuse low-grade glioma, NOS, and leave it at that and refer it to a larger center if it is required to do, or if the patient can afford to have these other testing done. So if you look at pediatric type diffuse gliomas, the singular feature is that there's long-standing history of epilepsy, children and young adults, usually an insidious onset. They're IDH wild type, H3 wild type. Two of them are OLIG2 negative. This is the angiocentric one, which has a very typical classic angiocentric pattern of tumor cells, and they are EMA dot-like positive. And the other, which requires demonstration of the MYB-L1 alteration. And then there are two that are OLIG2 positive. The one which we had as our case could have an astro and oligo-like look, more often oligo-like look on morphology. Definitely shows calcification, is CD34 positive, and one can make a diagnosis. But by WHO criteria, if you don't do the molecular tests, you have to stop at NOS. But you can give a more definite diagnosis of plenty. And the last one, again, you require to demonstrate this feature. Important to know this because oligo-like appearance is seen in many of these, but they are IDH wild type, and therefore they are not oligodendrogliomas. Oligodendrogliomas almost always IDH mutant. Right? So going on to the next case, before I go on to the next case, Dr. Tejpal, I've discussed two low-grade tumors. Would you like to say something?
Yeah, so I think there were a couple of questions I saw on the chat box. Is the treatment any different for these pediatric low-grade cancers? So I think the first line of treatment is surgery. Of course, in the midline location or the suprasellar location, a radical surgery is not possible, but a pilocytic in the cerebellum, pretty much a gross total resection is feasible. So you do a maximal safe resection in these tumors, and if you achieve a gross total resection, actually no further adjuvant therapy is required. As far as the diffuse low-grade astrocytomas or the pilocytic astrocytomas, which are residual or recurrent, we definitely treat them. And the current mainstay of treatment in children is systemic chemotherapy using vincristine and carboplatin. That's one of the common regimens that is used. In the last few years, increasingly, since we know that they are RAS-MAP kinase pathway or disease, inhibitors, the BRAF inhibitors and the MEK inhibitors are used. If you demonstrate a BRAF V600E mutation, then you use a combination of the BRAF inhibitor and the MEK inhibitor, and if there is a BRAF fusion positivity, then only a MEK inhibitor suffices. So in the last 5-7 years, I think there has been a change in the approach to managing these pediatric type circumscribed as well as diffuse tumors based on molecular alterations. One thing that I would just like to mention is that vast majority of these pediatric low-grade gliomas are actually RAS-MAP kinase pathway. So that is something that one needs to remember. Of course, all of them cannot be targeted by the BRAF inhibitors and MEK inhibitors. Some of them have FGFR alterations, some have some other alterations, but for the most part, a significant proportion of them can be treated successfully with BRAF inhibitors and MEK inhibitors. Of course, if you have excised them well, there's no significant residue, then you really don't need to treat them. And they have a very, very good prognosis. Most of these tumors have a very good prognosis.
Are there any other questions in the chat box?
No, ma'am.
So, to summarize, here the main thing is identifying a low-grade tumor compared to a high-grade tumor. So, all the features that make it low-grade in terms of cellularity and proliferation and so on. And then remembering that in a child, the diffuse gliomas, even if they have the morphology of an adult type tumor, actually have are CNS grade 1 tumors, and they're entirely different entities which can be picked up, which can be diagnosed either with immuno or molecular testing. And it's important because it really makes a difference to the prognosis and the outlook for the patient to be able to identify these tumors. So if, shall I just go on to the next case?
Tejpal, do you have any opinion? Tejpal, you like?
Yeah, so I just made some comments regarding the treatment which has evolved over the years. And previously, most of these children, say 20 years ago, actually used to get post-operative radiotherapy if there was a residual disease. Now, radiotherapy is no longer the frontline treatment after surgery. We would use either systemic chemotherapy or the targeted therapy with BRAF inhibitors and MEK inhibitors. We have to remember that these children, a significant proportion of these children get cured, and that's why we have to try and reduce the late effects of our treatment.
Thanks. So we'll go on to the next case, and this is with Burjir.
Yes, ma'am. Ma'am, we have case third, 16-year-old male, headache and vomiting for 1 month, and a blurring of vision and restricted eye movements on the left for 2 weeks.
So it's a short history, correct?
Yes, ma'am.
It's a short history.
Ma'am, should I describe?
Yes, please, Kajri.
So we have, this is what we call as a flare image. So I have not described it in my presentation, but this is exactly the same as T2. That means the gray is white and the white is gray, but here the fluid is suppressed. So this particular sequence often helps us to identify the edema, and the lesions are often better seen in this particular sequence. So here what we are seeing is there is a lesion. So this is your pons. The lesion is located in the posterior part of the pons, and it is a fairly well-defined lesion, I would say, and it is a little bit hyper-intense in flare, but the location is important. So the patient is presenting with headache and vomiting, and that is basically because the lesion is compressing upon the fourth ventricle. If we look at the sagittal, this is the sagittal T1 weighted image. So it's basically in the pons and medulla, as we can see, and it is compressing the fourth ventricle, and therefore it may occasionally be leading to features of raised intracranial tension, and that's why the headache and vomiting. And because it is located in the pons and it is affecting the cranial nerve nuclei, the patient is having visual symptoms. So that much we can say from this image.
Thank you. So it was a highly vascular tumor at surgery, and this is the smear preparation.
It's a hypercellular smear revealing sheets of cells without any particular arrangement, having fibrillary processes. And in the first image, the first caution is there was focal necrosis on one side. We could see necrosis.
Okay.
Yes, ma'am. And then the higher image of this squash, individual cells are spindled with elongated hyperchromatic nuclei, with many thin vessels traversing through these cells.
Okay.
And a fibrillary background.
I'll later on show you what thickened vessels look like. Here, although you're right that sometimes these tumors do have the vascular proliferation is seen as thickened vessels. Here, we're really just seeing it as parallel rows of endothelial cells. So I wouldn't quite say these are thickened in the smear, but it's very cellular, like you rightly said, and it's quite pleomorphic in appearance, right? So this is the fragments that we got of the tumor.
Ma'am, in this histopathology section, we can see 5 tissue bits that appear cellular at this power, and few of the bits show hemorrhage.
Yes, yes,
Diffuse hemorrhage.
yes.
In this one, when sections examined reveal hypercellular tumor, tumor cells comprising of pleomorphic cells having high NC ratio, hyperchromatic nuclei with prominent nucleoli, and eosinophilic cytoplasm.
I think you're seeing too many prominent nucleoli. There's one here, but yeah, okay. But yes, you're right. It's hyperchromatic. Yes.
And eosinophilic cytoplasmic processes blending with the surrounding dense fibrillary background.
Good.
And then there are few mitotic figures in this, and along with some vessels and hemorrhage.
Yes. So I also gave you MIB.
I think the index is more 60%.
Yeah, probably difficult to give a percentage with just an image, but you're definitely sure it's high, right? Compared to when I showed you the parasitic. So now you have the short history, a tumor in the brainstem, and with this high grade feature. So what would you like to do next?
I will go for IFC.
Okay.
My diagnosis, I think it's a diffuse midline glioma.
Alright.
So, I will do H3K27M.
Okay.
Then a GFAP for the glial cell to see it's a glial tumor. Then MIB we have already done. P53.
P53. Did you say P53? Okay. See, GFAP, yes, you can do it, but again, like in the previous one of the cases that I was mentioning, if you're very clear on it being glial, you can avoid doing the marker. Okay. So I'll just show you a few more images. Here are some more images of the same case, showing this cellular tumor, like I had shown you earlier, with this pleomorphism, and this is what is more of the thickened vessels. Can you appreciate that? When you see vascular proliferation on a smear, it looks like this, like finger-like thick structures. Okay. Can you make out the difference between this and this? Here you're just seeing thin. Here they're thick. Okay. And we had multiple fragments of tumor given to us. As you can see, they're very tiny, cellular, like you said, hypercellular, fibrillary background, lot of pleomorphism, and mitotic activity. So you're right in saying that it's a high-grade tumor. It's in a child. It's diffuse, and so your highest on the cards is a diffuse midline glioma. So this was OLIC2 positive. All right. And so now next you wanted to do an H3K27M. And how do you interpret this?
It is positive.
Showing diffuse positivity
Diffuse positivity
in the nuclei for H3K27M. Is there any other marker you can do?
We can do, if we have to differentiate it from oligo, because there are some oligo-like cells in it. So we can do IDH.
Actually, this is a very specific marker. A very specific marker that tells you that it is got H3K27 mutation. So now you really don't need to prove anything else. But there's one more marker that you need to do to make a confirmatory diagnosis. What broad group does this come under now? Or what is the full term for this tumor? Diffuse midline glioma. Then H3 what?
H3K27M.
That was the term that was used in 2016. Yeah, there's someone who's mentioned here in the chat box. H3 altered. Now, for altered tumors, basically, they show a loss of expression of a trimethylation protein. H3 trimethylation protein, loss of expression must also be seen. And here you can see the internal control is positive. So it in the new classification, it's called a diffuse midline glioma H3K27 altered. And I'll tell you why that is said now rather than mutant. And it's a grade 4 tumor. So these come under the group of pediatric type diffuse high grade gliomas. We just finished with low grade. And again, here there are 4 entities. And this particular one you saw came under the H3K27 altered. Now, you will see a loss of expression of the trimethylation protein, and it can either have the K27 mutation or it can have an aberrant expression of a protein called EZIP, or if it's a bithalamic tumor, it can show EGFR mutation. So, under the umbrella of altered, common factors, they all show this trimethylation loss, the H3 trimethylation loss. 2 of these will show the K27 mutation. This one shows EZIP overexpression, and this particular tumor is EGFR mutant, and this usually occurs in those who show tumors in both thalami. Both thalamuses are called. Now, in 2016, you are right, it was called the diffuse midline H3K27 mutant tumor. In the past, these were what we called intrinsic pontine gliomas. And but apart from the mutation in K27, what has been found is that this K27M and this other protein EZIP, they inhibit this polycomb repressor complex, and this is what mediates the trimethylation of H3. So when it is when it inhibits it, there is loss of trimethylation activity, and so you see a global reduction in the trimethylation protein. So when there's EZIP overexpression, it will inhibit the PRC2 and therefore inhibit the methylation activity, and then you see reduction in the methylation protein. So what was found was when we studied midline gliomas, there was a certain percentage that were K27 mutant, but there were also those that were wild type. And when they did methylation profiling, they found that these were those that had EZIP overexpression, and therefore they got included in the same group. Now, so all those which have this trimethylation loss are grade 4 tumors. They have a poor outcome. They occur predominantly in the pediatric age group, and they may have other alterations also along with apart from the H3 K27 alteration. Now, how do you interpret this? If it is a tumor like ours, which has showing the H3 mutation and trimethylation loss, it is an H3 altered tumor, but basically it has this mutation. There are those that don't have the mutation, have the trimethylation loss, but show EZIP overexpression. And those are also H3 altered tumors. All right. Now, here's an example of a tumor which is high grade with a lot of bizarre forms. H3K27 mutation is immunonegative. This is a highly specific marker for mutation. But there is a trimethylation loss, right? So this would, and there is EZIP overexpression in this case, right? The EZIP protein is positive. So this is a diffuse midline H3K27 altered tumor. Okay. Now they also found that in tumors that occur in both thalami like this, when they did a genomic analysis, they found that they had EGFR alterations, either an inframe insertion in exon 20 or mutation at exon 7. And these also had trimethylation loss. So why was it important to identify these group of EGFR mutant tumors? It was found that these particular tumors, when they're given the EGFR MEP kinase inhibitors, they have a far better prognosis compared to those that are not treated. So when you encounter a bithalamic, midline gliomas are those that occur in the brainstem and all the midline structures, but also in the basal ganglia. So in thalami. So when you see a tumor like that, in particularly in children, which is high grade, you have to think of these diffuse midline gliomas. Do the H3K27 and H3 trimethylation protein to diagnose it. If they are not K27 mutant but show the loss of trimethylation, works for EZIP overexpressed tumors, and if it's bithalamic, often they have EGFR mutations. So they generally occur in the pediatric age group. They can occur in the brainstem, thalamus, occurs in children and adolescents. Spinal cord astrocytic tumors, astrocytic morphology tumors. You have to think of this particular entity, and you can diagnose it using the markers that we just mentioned. So here's a high-grade tumor with an astrocytic morphology. Here, a very hypercellular pleomorphism. You may or may not see vascular proliferation and necrosis. It's got retained expression of ATRX. It's colic-2 positive. H3K27 is mutant, and there's loss of expression of trimethylation protein. So 50% of these tumors are P53 positive, and there are a few that show loss of expression of ATRX. But based on the location and based on these two markers, one makes that diagnosis. Someone says unable to see slides. Is that true?
No, ma'am, it is visible. I think it must be a connectivity error from there.
Okay. So if one does the Sanger sequencing, you can see that methionine replaces lysine at codon 27 of the H3F3A gene. And in the EGFR mutant tumors, you can either see a missense substitution in exon 7 or an in-frame insertion at exon 20. So prognosis important to diagnose because they have a poor prognosis. Though amongst these three, the one with the best prognosis is the one which has EZIP overexpression. And if you're young, less than 3 years or more than 10 years, you have a longer survival. And tumors that have EGFR mutation with targeted therapy have a better survival. So essential criterion, it's a diffuse glioma. All of them show loss of trimethylation protein, the midline in location. And in addition, either you should demonstrate the K27 mutation or the EGFR mutation or the EZIP expression or do the methylation profiling to match with the diffuse midline glioma. So in this particular case, Burjesh, histopathological classification, it falls into, it has an astrocytic morphology, right?
Yes, ma'am.
It's an astrocytic tumor. CNS grade is?
Grade 4.
4. Molecular information, what do you have?
H3K27 altered.
Yeah, it has both the mutation and the loss of expression, and we've done it by immunohistochemistry. So what would be your integrated diagnosis? Diffuse
Midline glioma, H3K27 altered.
Yes. Then
Grade 4, WHO grade 4.
WHO grade, CNS WHO grade 4. Because these markers have, you've got all the criteria fulfilled for this tumor. So that's about the midline gliomas. I'll quickly run through the others because in Dr. Vani's session she said I would cover this. So I'll just quickly tell you about the other high-grade diffuse gliomas. Before that, Tejpal, do you want to say something or shall I finish this and then you'll speak?
Maybe you could just finish, then I can.
Okay. So then you have, apart from those that occur in the midline, you have those that occur in the hemispheres. And amongst this one is the H3G34 mutant tumor. This is also a grade 4 tumor. And it results from substitutions of histone with the G34V, replace alterations at the in the histone at G34. So it occurs in adolescents, young adults, and cerebral hemispheric involvement. You can see a GBM-like appearance, that means a high-grade appearance, a primitive appearance, mitotic activity, proliferation, necrosis. You'll be thinking of a glioblastoma or a primitive neuroectodermal tumor. but these are IDH wild type tumors. They can show loss of expression of ATRX and overexpression of P53. But the one feature that they have is Dr. Vani also mentioned this, the lack of OLIC2 expression. So normally, when you see a high-grade tumor, you're thinking of a high-grade tumor like a glioblastoma, astrocytoma grade 3, or even in this, if it's a neuroectodermal-looking tumor. But they will have loss of expression of ATRX, which suggests that it's a glial tumor. They have overexpression of P53, again pointing to this astrocytic morphology, but they have absence of OLIC2. When this three are seen together, one has to think of this entity. Ideally, by sequencing, you demonstrate the replacement of arginine with valine, but otherwise, there is a specific immunohistochemical marker available for HCP34 protein. So here's an 18-year-old child with the generalized tonic-clonic single episode, so short history, and a hyperintense lesion seen in the posterior central gyrus, and there's some enhancement of the tumor here. And you can see what is this here, Pujesh? Necrosis, and this is palisading necrosis. You're seeing microvascular proliferation, you're seeing multinucleated giant cells like this, and it's showing loss of expression of ATRX, P53 mutant, but it is OLIC2 negative. And therefore, one has to start thinking of this tumor with this combination, and here it demonstrates the positivity for this immunohistochemistry. So this, by sequencing, one can show the arginine replacing glycine or valine, and here, so it's you can either do it by NGS or by immunohistochemistry. In addition to this, often these tumors have NGMT promoter methylation seen, and that is why they may have a better prognosis even though they are grade 4 tumors. Quite a few of them show the CDKN2A homozygous deletions. So in this particular group of tumors, if you look at survival, it's a slightly better survival, and probably because they have this NGMT promoter methylation in them. Remember that they are OLIC2 negative tumors. So by criterion, it is essential to demonstrate the molecular alteration. The hemispheric tumors, desirable to have this 3 combination to make you think of this particular high-grade tumor. The infant-type hemispheric gliomas occur in infants, and here there are 3 subgroups of these tumors. Most of them show these alterations. Here you can see that they're fairly large tumors. I've taken this from a publication of infant type, a large series. And what you see in these tumors are the high-grade tumors. They have receptor tyrosine kinase fusions, including those in the NTRK family, or they have ROS1 alterations, ALK1 alterations, or MET alterations. They have not yet been assigned a CNS grade, typically seen in the less than 1 age group. So if you see a large tumor in an infant, one has to start thinking of an infant-type hemispheric glioma. They are highly cellular, high-grade tumors, lot of mitosis, OLIC2 positive, and high MIP proliferation index. They may show some desmoplasia. So the importance of this is that actually though they are these diffuse high-grade tumors, they tend to have a better survival compared to other pediatric high-grade tumors seen in older children. And they say that if they survive past 2 years of age, they don't really progress. And depending on the molecular alteration present, targeted therapy is available with small molecule inhibitors, and therefore improves the prognosis. So if you look at them based on their molecular alterations, the lowest survival is in the ROS1 altered tumors, whereas the best survival is in the ALK altered tumors. So for this, it has to be an astrocytic tumor seen in infancy and early childhood, hemispheric in location, and one has to demonstrate the molecular alteration to make this diagnosis. And the last is the H3 wild type, IDH wild type. These tumors, as the name suggests, have to show a demonstration of both IDH being wild type and H3 being wild type, which means you have to do it by molecular testing. It's a CNS grade 4 tumor. Usually it's associated, the location of the molecular alteration defines its location. Median age is 10 years. And here again, we have high grade features. They may have primitive features, and they show ATRX loss, P53 mutation, but they're IDH wild type, H3 wild type. And this is how they can look, almost like a glioblastoma with this palisading necrosis or this very primitive or bizarre appearance. And here you can see that trimethylation is the protein is retained, H3K27 is negative, IDH is negative. You have to then do molecular testing to make sure that is there. And then for these three molecular subtypes, RTK2 is EGFR amplification is seen in almost 50%, or third promoter mutations. In RTK1, PDGFR amplifications, and in the MICN group, MICN amplifications. And importance of this is that they have a poor survival. So here again, you have to demonstrate IDH wild type status and H3 wild type status and prove one of these to make a definitive diagnosis of a diffuse high grade glioma. So if you look at all diffuse gliomas that are high grade, you divide them into midline and hemispheric. In the midline group, you first approach with the K27. If it's positive, you look at the H3 trimethylation, and this is your diagnosis. If K27 mutation is not there, but trimethylation lost, it's either an EZIP overexpression or EGFR mutation. And then in the hemispheric group, the infant group have these alterations in NTRK, ROS, ALCOM, MET, and they're infant type hemispheric. And in children, the H3G34, if they have OLIC2 negative, ATRX positive, P53, they are the H3G34 mutant. And the last are those which are H3 wild type, IDH wild type with the specific alterations. Okay, so you don't call them glioblastomas, or you don't call them astrocytoma grade 3, but you first prove that it's not one of these entities. Tejpal?
Yeah, so I think the pediatric high-grade gliomas are the most challenging tumors in children, and as Madam showed, the diffuse midline gliomas have the worst outcomes. Despite, the case that was shown actually was looking like a circumscribed glioma. What I wanted to just emphasize was that many a time they would not enhance. They don't look like high grade, very high grade on imaging, and that should not sort of be a. You should not get carried away by that, because most of the time we don't see a lot of necrosis or enhancement in these diffuse midline gliomas. The molecular characteristics have been well described. The treatment as of today remains radiotherapy. Most of the time they are not amenable to resection. You can just take biopsies. In the DIPG, the diffuse intrinsic pontine glioma, we don't even take biopsies. We treat them based on clinical radiological grounds. The outcome still remains very poor. Most children succumb within a year of diagnosis. The hemispheric gliomas are somewhat better, but still not good prognosis. Their treatment is also maximal safe resection followed by radiation therapy. The only silver lining in this is the infant hemispheric glioma, which many a times is has alterations that can be targeted. And in fact, we have 3 children of infantile hemispheric glioma at TMH in the last 2 years who have subtotal resection, but despite no treatment, they're still doing well alive, despite not having any targeted therapy. The NTRK fused tumors, you can target them with NTRK inhibitors, larotrectinib and entrectinib, but even without inhibitors, they may actually do well. We are learning more about these tumors, but overall, pediatric type diffuse high-grade gliomas is a bad biology piece.
Thank you. So you're right about the fact that that particular case was circumscribed, and which is why the surgeons were surprised when we gave a diagnosis like we did. But this K27M is a very specific, robust marker, HCK27, and if you get positivity with that, you can be 100% sure that you're dealing with an HCK27 mutation. So that, together with the trimethylation loss, kind of clinches the diagnosis. And so sometimes, yes, radiology can be misleading. Even in that plenty case, didn't really have a classic appearance of a plenty on radiology. But by
Yes, ma'am.
histology,
Yes.
that's what we have.
But obviously, we need to see the rest of the sequences. So, if I would have been asked to give a differential on this particular case, I would especially look at the contrast and the diffusion. Because if this was this particular tumor looking like this, which is projecting posteriorly and a very well defined tumor, it was intensely enhancing, I would think of a pilocytic. Obviously, if it is not enhancing, I have to think about a diffuse midline. But in that case, that's what is the importance of looking at all the sequences before commenting on anything, before actually giving a differential.
Yes, so exactly the same thought, Kajri. I thought that this was a dorsal exhibiting pilocytic
Yes.
astrocytoma,
Yes.
just
Yes.
based on that flare image.
Yes, sir. Yes.
Ma'am, I have a question.
Yes.
For this case, if there was a frozen section asked for, how do we frame the diagnosis?
So when a frozen section is asked, particularly for a brainstem lesion, it's usually a stereotactic biopsy because they really can't go excising a tumor from the brainstem, right? So that situation, the surgeon is really just wanting, first of all, to know whether they've hit the lesion and whether they've got enough tissue for us for a definitive diagnosis. So the first step is on the smear. You could see that it was definitely looking cellular and had a fibrillary background. There was pleomorphism. So we know that we had got tumor. So that's the first information that you want to give them. They are in the tumor. Now you can make out in this particular case that there's no pilocytic features, there is no Rosenthal fibers, there are no eosinophilic granular bodies, and you've seen some mitosis, so you're now veering towards a high grade. So all I would tell them is that they've got a glial neoplasm. It's likely to be high grade, but I definitely want more tissue to be able to do the immuno. And so when you have these tiny pieces of tissue, very often at the time of the frozen, the smear itself, we make sure that when we process the tissue, we very carefully cut extra sections for our immunohistochemistry, because otherwise the whole thing may get trimmed off and you're left with nothing. So particularly in these tiny biopsies from the brainstem, one has to think ahead of that. So to answer your question, my response to the surgeon would be that it is a glial neoplasm. It's likely to be high grade. And at that point, they only want that much information. They're not really going to do anything more till you can do your markers.
Thank you, ma'am.
Tejpal, is that correct?
Yes, ma'am. I think for the surgeon, they just need to know whether a representative tissue, they've hit the right place for making a definitive diagnosis. You can't go ahead and excise these tumors, so you're absolutely bang on. Just need to tell them that it is a glial tumor which is likely to be high grade.
Yes, and to save ourselves, we also, in case they get carried away, you remind them that you want more tissue for immuno, so that before they take the frame off, they give you some more tissue. So, yes, okay. Having said that, I also want to say that if you are really stuck and don't have any more tissue, you can also do immuno on the smear itself. Rarely we have had to do that, and immunohistochemistry works just as well on the smear. Okay, so going on to the fourth case, this goes to Shanti, I think. Is that correct?
Yes, ma'am.
Okay.
Ma'am, this is an 8-year-old male presenting with vomiting since 20 days, imbalance while walking since 15 days, and headache since 3 days.
Okay. So again, a very short history showing that there is some raised intracranial pressure, and this is the tumor. Kajri?
So we have 3 sets of images. This is a coronal T1 weighted image. So what we can see is basically this is Probably, so I would have to see the rest of the scan, but probably looks like an extra axial lesion, or maybe it is arising from the CP angle, or it's basically an off midline lesion. Yeah, so this axial section gives a better picture. So this is an axial T2 weighted image. We can see a lesion which is arising in the region of the left cerebellopontine angle, or basically in the region of the middle cerebellar peduncle. So at this point of time, it may be a little bit difficult to comment whether it's actually intraaxial or extraaxial, but definitely it is an off midline lesion which is in the posterior fossa, and it is adjacent to the adjacent to the fourth ventricle, and it is arising in the region of the CP angle cistern or in the middle cerebellar peduncle. One very important thing which we can see in this particular case is that if we compare it with the previous imaging, this looks much more hypointense on T2, which signifies that this is likely to be a more cellular tumor. So I would think it to be a more cellular tumor. Second thing is it's more heterogeneous. So if you see, there are some areas of central T2 hyperintensity which are appearing more bright, and therefore this is a heterogeneous tumor. On post contrast also I would expect a heterogeneous enhancement. Another thing is it is maybe extending along one of the fissures, so basically it may have a extension to the from intraaxial to extraaxial extension that could point to be some that could have something which is called as the toothpaste like or plastic type of extension, so that could be there. And one final thing is that it is it's well circumscribed. So basically the location is in the posterior fossa. It's more or less well circumscribed. It has an extension towards the CP angle cistern, and it's a heterogeneous tumor with predominant T2 hypointensity with some hyperintense area. So this much may be my description.
It seems to be crossing the foramen magnum as well, no? I mean,
yes, maybe, sir. We have to look at the further images. Maybe it is crossing. So maybe it is having, so obviously T1 it is seen. So yes, it is crossing. So in that case, so my differentials, I have made my mind, but as madam has told, I would not tell my differentials. But there are one or two differentials in this case, but then we have to look at the rest of the pathology.
So it was a moderately vascular tumor, and Shanti, you can start with the smears.
This is a squash cytology smear, which shows hypercellularity with tumor cells arranged around the blood vessels in a rosette format. And these cells have a delicate cytoplasmic process.
I haven't given you much more by way of images of the smear over here, but you can appreciate this perivascular alignment of tumor cells. Okay, then.
Here the tumor appears to be circumscribed from the surrounding parenchyma, and we can see true ependymal rosettes and pseudo perivascular rosettes, rosette arrangement of the tumor cells. Here also the perivascular arrangement and true rosette formation can be seen.
They're mainly perivascular. No? But one thing you can say is that it's hypercellular, right? It's very cellular.
Yes.
And you're seeing this perivascular kind of arrangement. And here, what do you see here? All this?
Necrosis.
Yes. And you said it was circumscribed, but actually this image that I've given you, you can see that it's infiltrating also.
Yes.
So it depends. Here you're seeing this necrosis and all this very cellular tumor.
Yes.
Other areas you're seeing a less cellular infiltrating tumor. So that also I had given you. So here you have the true ependymal rosettes. There are no vascular channel here. And these areas are more low grade, isn't it?
Yes,
it's looking much less cellular than the areas that we saw over here. Correct?
Yes, ma'am.
So here now, the low grade areas also are
showing tumor, perivascular rosettes with anucleate zone.
Yes. So classic appearance. What are you thinking of?
Posterior fossa ependymoma.
You're thinking of an ependymal tumor. So let's start with what would you do to confirm that it's an ependymal tumor? What if I said it was because it's got rosettes that it's a medulloblastoma? Or what marker would you do to confirm your diagnosis of an ependymoma?
H3 PK28 and
No. That is if you're thinking of a midline glioma. You're saying ependymoma, right?
yes.
So for an ependymoma, what are the markers that you would do to prove that's an ependymoma?
Glial fibrillary protein will be positive.
Yes. Good. Then
Epithelial membrane antigen can show a paranuclear dot-like
very
positive.
good. So just a few more images of the same tumor. This, what do you think this is here?
The ependymal canal.
Yeah, this is actually part of the fourth ventricle that you're seeing here. And you have the tumor going low grade and high grade areas.
Yes.
With these true rosettes here and the hypercellular areas and the area of necrosis. So you can see these are the true ependymal rosettes. Yeah? No
yes.
vessel inside it.
Yes, ma'am.
And the hypercellular areas with the mitotic activity.
Yes, ma'am.
So you have hypercellularity, perivascular rosettes, true rosettes, mitotic activity, and necrosis. So now you said your GFAP is positive.
Yes, ma'am.
And EMA is showing this dot-like paranuclear positive. So now your diagnosis is that it's likely to be an ependymoma. And you went as far as saying that it is a posterior fossa. So why did you say that?
Because of the location in the radiological location.
Good.
It's in near fourth ventricle.
Yeah, it's in the posterior fossa. So ependymomas now are grouped, like you rightly said, based on the anatomic site, whether it's supratentorial, posterior fossa, or spinal cord. And there are molecularly defined subgroups in each of them. So by methylation profiling, the posterior fossa are group A and group B, and group A is further subdivided. And the supratentorial has the ZEFTA fusion and the YAP1 fusion. One thing that you must remember is all three compartments, the supratentorial, the posterior fossa, and the spinal group, have the subependymoma as one of their tumor types, one of their tumor subtypes. In the spinal, you also have the myxopapillary ependymoma, and then you have the subependymoma, and then you have the high-grade MYC-N amplified tumors. In the supratentorial, you have the subependymoma, the ZEFTA fusion and YAP fusion. And in the posterior fossa, the subependymoma in group A and group B. So that's what this shows. You have the supratentorial, posterior fossa, and spinal. All of them have a subependymoma as one of their types. In the supratentorial, you have the ZEFTA fusion and the YAP1 fusion tumors. In the posterior fossa, you have A and B. And in the spinal, you have the regular ependymoma, the myxopapillary, and the MYC-N amplified. And which are the ones of prognostic relevance? It's already shown here, but Shanti?
Yes, please.
The ones with the worst prognosis is the
posterior fossa group A ependymal.
Yeah, and the spinal MYC-N amplified tumors. So these were earlier called the RELA fusion tumors, but the fusion partner is not always RELA, and therefore they are called ZEFTA fusion positive tumors. Most of them are 70% of them supratentorial tumors are the ZEFTA fusion tumors. Some of them are YAP1 fusion, and these are usually seen in children less than 3 years. Supratentorial means above the tent, often have a clear cell morphology when it's a ZEFTA fusion, and here the rosettes and the pseudo rosettes are rare. Whereas one way to identify this YAP1 fusion is they often show eosinophilic granular bodies. So when we were talking about eosinophilic granular bodies, remember that this is another tumor that can show eosinophilic granular bodies in them. They're seen in mainly children less than 3 years. Importance is that they have a slightly better prognosis than the ZEFTA fusion. In the posterior fossa group, you have the A and the B. The A group is seen in younger children, whereas B is seen more in adults. And they show this trimethylation loss. Remember, I told you that trimethylation loss, trimethylation inhibition occurs either with the H3K27 mutation or with EZIP. So these tumors show EZIP overexpression, and when they show retained expression of the trimethylation protein, then they are classified as group B tumors. In the spinal, remember that all three have subependymo as one of their types. The spinal group has also got the regular and the myxopapillary, and in addition, the high-grade version is the MYC-N amplified tumors. So in this particular tumor, it showed a loss. What is this? What do you think this is showing?
HDK27.
Not K27. It's 3-trimethylation protein loss, right? So, like I said, you have this methyltransferase activity inhibited. So, there is reduction in the HDK27 trimethylation protein loss. It's not the HDK27 mutation, but the K27 trimethylation protein loss seen as a loss of expression. And here this tumor also showed EZIP overexpression. So essential criteria is demonstrating that it's an ependymoma in the posterior fossa, but also showing either a global reduction in the trimethylation protein or a DNA methylation profile to match the PFA. So in this case, Shanti, for an integrated diagnosis, your histopathological classification is that it is an ependymoma, and it's a grade, I've already put it, grade
3.
Grade 3. Actually, grading is very controversial. They say mitotic activity, necrosis, and vascular proliferation indicate a higher grade, but there is a lot of controversy about whether grading actually correlates with prognosis, and it's more the molecular subtyping and the location that correlates with prognosis. So in this case, we have the molecular information available, because there was loss of expression of trimethylation protein. So what would be your integrated diagnosis?
Posterior fossa ependymoma group A.
Good. With the CNS
grade 3.
Yes.
CNS grade.
Yes, good. So that's the final diagnosis in this case. Just a few more images for you all to be familiar with ependymomas. These are the perivascular rosettes seen in ependymomas. Here you can see a vessel with this alignment of this processes, a nuclear zone and then the tumor cells. Here you're seeing true ependymal rosettes. Again, here, example of true ependymal rosettes where you have a central lumen and tumor cell nuclei arranged around it. And rosette is, the name comes from these rose windows that are seen in stained glass in Gothic cathedrals. And essentially it just has this arrangement of tumor cells around a central zone. So there are some named ones, and this is homerite rosette seen in medulloblastomas, neuroblastomas, and primitive neuroectodermal tumors, where you have tumor cell nuclei and the central zone is neuropil. So does anybody know who homerite was? Well, he was a director of Massachusetts General Hospital, and I guess he identified this, and this was named after him. Then comes the flexner of intestina, which is seen mainly in retinoblastomas. They have the central lumen and tumor cell processes, and then the tumor nuclei. Flexner was a pathologist, and Wintersteiner was an ophthalmologist, and so this rosette is named after them. The perivascular pseudorosette has the vessel in the center, and then the tumor cell nuclei. And the pineocytomatous rosette has a large area in the center with neuropil with tumor cell nuclei around it. So what type of rosette is this? Homerite rosette. This one?
This one is true preserved
ependymal rosette. This?
This is my perivascular
pseudo. Good. And this?
It's also pseudo rosette.
No, this is not a pseudo rosette. You have this and then this.
The last one.
Large ones. So these are the pineocytomatous rosettes. They're very large. Okay, that's what they look like. This, what is this showing you? This is a feature seen in some ependymomas. This is called canalicular differentiation. It's trying to form these ependymal canals. Alright? And you can see lining of ependymal cells. And classically, ependymomas have these tumor cell nuclei which are very evenly dispersed nuclear chromatin and very monomorphic looking, even if when they're hypercellular. In a grade 3, you see this kind of cellularity, which is very different from the lower grade ones, which don't have as much cellularity. Can see mitotic activity, like you see here, and microvascular proliferation. Necrosis by itself does not affect grading because sometimes you see it as some kind of infarction, but palisading necrosis has some relevance to grading. And like you said, they're GFAP positive and they show this dot like positivity for epithelial membrane antigen. I'll just say something here. Epithelial membrane antigen, we use it for epithelial tumors, we use it for meningiomas where you get cytoplasmic positivity. But in ependymomas, you see this dot like positivity. And in my own experience, I find that the immunohistochemical marker that we buy and use for epithelial tumors, the dilution that we use it at does not work for ependymomas. So if you want to demonstrate this, you should do it at a higher concentration. In our lab, we use it at a 1 in 50 dilution. 1 in 10 dilution, whereas normally we use it in 1 in 50 for other tumors. So for these tumors, when we're thinking of this, we tell the lab, use a more concentrated version of the antibody, and then you'll be able to see these dots quite easily. Myxopapillary ependymoma, just to complete the whole thing on ependymomas, they have the not necessarily looking papillary, this myxoid collars around vessels with this bluish background, and that stains positive with Alcian blue. They used to be called grade 1 tumors. Important to know now that they are all they're graded as grade. They start at grade 2. Myxopapillary start at CNS WHO grade 2. And subependymomas, whether they're supratentorial, posterior fossa, or spinal, are grade 1 tumors. So here again showing you this dot-like positivity for EMA. The MIP in a low-grade ependymoma is low and on a high grade is high, so that sometimes helps you to differentiate. Posterior fossa ependymomas, the trimethylation retention is seen in PFBs, and to call it a PFA, more than 80% of the tumor nuclei have to be negative, have to show loss of expression. RELA fusion can be demonstrated by FISH, and this is an example of a C11 ORF95. But like I said, RELA is not the only fusion partner, and the one surrogate marker for the supratentorial ZEFTA fusion cases is a protein called L1-CAM, and that shows positivity in the cytoplasmic processes in supratentorial tumors that are ZEFTA fusion positive. The spinal ependymomas, the high grade ones, not in all the spinal ependymomas, but the ones which look high grade, one can suspect a MICN amplification, and this can be molecularly looked at or with FISH. And now there is a nuclear marker available by immunohistochemistry, which is a surrogate for MICN amplification. So, Dr. Tejpal, you comment on the others and this tumor?
Yeah, so I think, what we need to remember is that the BF ependymomas, which are much more common in children. So I think ependymomas, the most common location in children is the posterior fossa, and while in adults is the supratentorial brain. Generally, spinal ependymomas are more indolent than either the PF or the supratentorial ependymomas. And most young children, less than 3 to 5 years of age, have a PFA ependymoma, which is the bad player. And now we have these markers to diagnose them molecularly. The PFB ependymomas are much better in terms of prognosis. And as Madam pointed out, histology probably, the molecular biology trumps the histology as far as ependymoma is concerned. And a PFB grade 3 ependymoma probably will do much better than a PFA grade 2 ependymoma. So that's how in ependymoma things have changed. Supratentorial ependymomas, there has been this acknowledgement that this ZFTA altered or the RELA fusion positive are bad. But recent literature suggests that they are not a very homogeneous group, and many groups have demonstrated that despite ZFTA fusion positive, the outcome is not so bad. Of course, YAP1 is better, but again, ZFTA doesn't necessarily mean poor prognosis. Till a few years ago, it was considered to be poor prognosis, but now we know that the ZFTA altered, all of them are not having a bad biology.
Also, in supratentorial ependymomas, those that occur extraaxially in the parenchyma, my experience, those are more often seen in children and have that clear cell phenotype and azefta. The clear cell phenotype, if you see, like almost looks like an oligo, clear cell morphology, one can suspect zefta fusion.
So actually, imaging characteristic, I mean, most of the time, the supratentorial ZFTA altered in children will be a large cystic ependymoma, cortical ependymoma with smaller solid component, and not very close to the ventricle. You're right; they are mostly.
I meant extraventricular. Sorry. Yeah. Sorry. Yeah.
Extraventricular.
Yeah. Yeah. So when they're extraventricular and in children, and with that clear cell morphology, zefta is high on the cards, right?
Yeah, even as I said on imaging, now most of the time we are actually able to tell large cyst is one of the common features of a ZFTA altered extraventricular location in a, say, a 3-year, 4-year, or a 5-year-old child. Most often we will get the ZFTA alteration. See.
All right, and prognostically, the two bad ones are the zefta fusion or at least the supratentorial with the high grade. Like you said, there is some heterogeneity in their prognosis there, and the spinal MICAN amplified. And
yeah, MICAN amplified is poor, and PF is universally poor.
Bad. Is there anything else there? Any questions? Otherwise, we move on to the next case. Good, Shanti, you did well with that case. So we move on to the last one. This is to Shatabdi.
Good evening, ma'am. Good evening, ma'am.
Yeah, good evening.
Case number 5. The patient shows complaints of imbalance while walking for the last 2 months.
I'm sorry, I think I missed giving you the age. It was a child. I think I mentioned it in one of my earlier versions, but it seems to have got cut. Okay. Kajri?
Yes, ma'am. So this is an actual post-contrast T1 image. And in this one, this also it looks in the similar location. It's basically a CP angle cistern lesion, which is present on the left side. And in this post-contrast image, we can only comment that it's a heterogeneously enhancing lesion. So the peripheral portion of the lesion is showing some enhancement, and the central portion is showing necrosis. Do we have only one image, ma'am, for this?
Yeah, I've only
one. Okay, fine.
Kind of focus on that. Yeah. So what we had here was that it was a very vascular tumor. Surprisingly, had a well-defined plane, but was also arising from the vermis, but there was a kind of clear plane of demarcation in some areas of the tumor. So let's go on to the slides, Shatabdi.
And in this slide, it shows cerebral cortex where we see the convoluted gray zone area, which is supported at the central by branching white matter. And at the periphery of the gray matter, we see multiple diffused small round blue cells.
Are those tumor cells or normal cells?
It seems to be tumor cells.
So I deliberately kept this image, this picture, because I wanted you all to be cautious of this. These are the cerebella folia, and this is actually the leptomeningeal tissue in between. Okay, this is the molecular layer of the cerebellum. And then this is the granular layer, and then comes the white matter, which we are not really seeing except maybe here. So these cells in the granular layer look like dark blue cells. But actually, when you see it on hyper, they'll be very monomorphic, no mitotic activity, and so on. And you have to be aware of this because what happens in tumors that are high grade and blue, which we're going to see shortly, the adjoining nervous tissue can, like this, can look discolored intraoperatively. So when the surgeon goes in, they see these discolored areas and they give you this for frozen. And you do a smear on something like this and you say that it's a high grade tumor, you would be wrong because it's probably only the granular cells that you're seeing of the cerebellar cortex. And one clue to it is you'll also see some pink zones and these Purkinje neurons that are normally present in between. So I just wanted you to be aware that these granule cells can be very deceptive, but will be mitotically, there'll be no activity. So that was the normal tissue submitted, and this is actually the tumor. Go ahead.
Ma'am, in this section, we see at the low power, we see multiple microvascular pale iron areas.
Micro nodular or vascular?
Micronodular, ma'am.
Nodular. Pale areas, yeah.
And in the much higher vision, we see again this soft tissue shows multiple micronodular reticulin-free pale islands, which we indicates.
How
And
do you know it's reticulin free? You can't, at this point, you can't say it's reticulin free, right? For reticulin free, you need to do a reticulin stain. This is only an H&E, correct? So you're right, you're seeing some paler nodules and they're surrounded by more
plasmoplastic areas, plasmoplastic tissues.
Shatabdi, you have to be a bit careful. Huh? Desmoplastic, reticulin, all that is seen only with the reticulin stain. What you're seeing here are these hyperchromatic, hypercellular, internodular zones. Do you agree? These are more cellular than the central, these nodular zones. So at this point, you can only say that it has a nodular morphology with these hypercellular zones and the nodular pale zones. Correct? Do you agree?
Yes.
You have a diagnosis, I know, and you're trying to get to it, but you need to only be able to, you cannot come to that without those special stains. So now you have further hyper view of these areas. You want me to
Ma'am, in this picture, we see multiple hyperchromatic round to oval types of cells, mainly the small blue types of tumor cells have been appreciated. Along with, we can see some mitotic activity.
Yeah, that's better seen on this hyper, where this internodular zone is showing you. Yeah, it's showing.
Ma'am, in this round to kind of polygonal type of tumor cells with small blue tumor cells has been noted, but increased mitotic activity.
There is a high nuclear cytoplasmic ratio, right? So it's hypercellular. There's a high nuclear cytoplasmic ratio, which means the cytoplasm is scanty. The nuclei are oval to elongated, and the cytoplasm is scanty, and you're seeing possibly some mitotic activity. So with just this much, with this nodular appearance and this, which group of tumors are you thinking of, and what would you like to do next?
Here I'm thinking of a kind of embryonal tumor of the CNS.
Yes, it's in the cerebellum.
Cerebellum.
So which is the embryonal tumor often seen in the cerebellum?
And medulloblastoma.
All right. So you were talking about various terminologies you used while you were describing. Is there a special stain you want to do?
A special stain, reticulin stain can be done.
Okay. So you want to do a reticulin stain, and immunohistochemically, what marker will help you confirm a diagnosis?
Synaptophysin.
Yes. So you would do synaptophysin, GFAP, and to make sure it's not a high-grade glial tumor. So this is the reticulin stain, and what are you seeing here now? Now you can say what you were saying earlier.
Yes, ma'am. In this section of the IHC, of the special stain, sorry, ma'am, it's a special stain. We can see multiple micronodular pattern with reticulin free area. This is a pale iron, which is separated by nodular high grade
reticulin rich areas. Okay.
Reticulin rich areas.
Synaptophysin is showing positivity with
positivity of the nodule, micronodules.
Yeah. So some more images here for you. Here again showing this nodular appearance with the internodular hypercellular areas, paler nodules. And the pale nodules have more of the stroma present. You want to describe this nodule for me, Shatabdi?
Ma'am, this nodules, it looked like a hyperplastic follicular, it's a lymphoid follicle, it may seem like.
Are you saying you're talking about the germinal center? Almost like a
no, ma'am. It might look like it's the micronodular pattern. It might.
Well, it's got a pale background and a lot of neurophil compared to in the internodular zones. And these tumor nuclei are a little bit more uniform than the ones in the hypercellular zones, right? So you're seeing these have more uniform nuclei. Yeah. And they're also showing these perinuclear halo-like appearance. So that's almost like a neurocytic appearance. So this is the hypercellular zones which we saw earlier. This is the reticulin, and this is a higher power of the reticulin showing the pale zones with no reticulin and the internodular zones which are got dense pericellular. Yes, pericellular. So sorry. So what is your diagnosis now?
Ma'am, my diagnosis is medulloblastoma.
Yes.
Which is a CNS WHO grade 4.
Yes. And now that you've seen all this, nodules and what is called desmoplasia.
Ma'am, it comes under the histologically desmoplastic or nodular variant.
Good. So it would be a medulloblastoma, desmoplastic or nodular by histological definition and a CNS grade 4. So medulloblastoma, like you said, is an embryonal tumor seen in the cerebellum, high nuclear cytoplasmic ratio, high mitotic activity and apoptosis. The WHO defines them histologically and molecularly. Molecularly, there are some subtypes. The other CNS embryonal tumors, there are a whole lot of them. Many of them are newly described entities. I'm not going to go into all of them. But two tumors that one needs to differentiate the medulloblastoma from are the atypical teratoid rhabdoid tumor, which can have very primitive looking areas. And so one of the criteria is atypical teratoid rhabdoid has loss of INI1 expression. And you have to demonstrate retained expression of INI1 in medulloblastomas according to WHO. Embryonal tumors with multilayered rosettes also have a very classic appearance if you can see the multilayered rosettes, but otherwise this has to be one of the differentials to be considered. We'll go back to that later. Medulloblastomas occur actually at all age groups, but is most common in childhood and the second most common CNS tumor of childhood. And about 25% of medulloblastomas occur in adults. So when you look at it by histological definition, there are four types. The classic, the desmoplastic nodular, which we saw, Medulloblastoma with extensive nodularity is essentially this with very scanty internodular zones. I'll show you a picture. And the large cell or anaplastic are medulloblastomas that have either large cells with prominent nucleoli, a lot of pleomorphism, or anaplastic features. I'll just demonstrate some of it to you. I'm going to go a little fast because we are already at 9:15. So 78 to 80% of all medulloblastomas are classic. They occur at any age group, whereas the desmoplastic nodular, less than 3 years, desmoplastic nodular accounts for 40 to 60% of medulloblastomas that you see. On the other hand, the extensive nodularity in children less than 3 years, a fair percentage of them are this extensive nodularity tumor, whereas large cell or anaplastic can occur at any age group. So when you look at it by location, the classic can occur in the midline, often involving the fourth ventricle, whereas the desmoplastic nodular is in the cerebellar hemisphere, but also involves the vermis. The extensive nodularity likewise is also vermian and can involve the hemispheres. The large cell anaplastic are typically in the cerebellar midline. So they're all kind of friable masses, but the desmoplastic is firm and circumscribed. Remember, we had a fairly circumscribed tumor in our case intraoperatively, and in MEBENs you tend to see a grape-like appearance grossly. So on a smear, you see a hypercellular tumor, and on the cryostat section also you see high nuclear cytoplasmic ratio and a hypercellular tumor. You may see this palisading of tumor cells in some of these cases on frozen. The classic is just looks like a polydifferentiated tumor, high blue cell tumor, high nuclear cytoplasmic ratio, frequent mitosis. They say they have carrot-shaped nuclei, basically long nuclei. And another feature of medullos, apart from mitosis, is a lot of apoptosis. Lots of vapor. You see this nuclear debris-like thing all over the place in medulloblastomas. What are these?
These are rosettes.
Which rosette?
Homerite rosettes.
The homerite rosettes, which can be seen in these medulloblastomas, and they're synaptophysin positive. Now, leptomeningeal spread has prognostic significance, and often they will examine the CSF afterwards for us to say whether there's seeding of the CSF. But sometimes your section itself will show you the leptomeninges with tumor within it. You can see there's a molecular layer, granular layer, Purkinje cells, and this is therefore the surface, and there's tumor on the leptomeninges. A higher power view of the same. So the desmoplastic nodular has this biphasic pale nodules and the hyperchromatic internodular zones. The reticulum is rich in the hypercellular areas, and these densely cellular zones are more high mitotic activity, high proliferation index, whereas the nodules are more mature with the neuropil and what they call as neurocytic, looking like the neurocytes that you see in a neurocytome. The reticulum shows this desmoplastic internodular and pale nodular zones. You can appreciate that here, right?
Yes, ma'am.
And the synaptophysin in a desmoplastic nodular stains the nodules and not so much the internodular zones. The extensive nodularity shows nodules but a very expanded nodule, almost like lobules with scanty intercellular zones. And if you see it on retic, you can see that the intercellular zones are very scanty and thin, and the nodules themselves are expanded. Okay, that's the difference between the two. The internodular component can be scanty, and the nodular zones are very rich in neuropil and have this neurocytic differentiation. Sometimes it can mature even to showing some ganglion cells. The large cell phenotype has these large cells, prominent nucleoli, vesicular appearance, and the anaplastic has high mitotic activity, lot of pleomorphism. Again here, brisk mitotic activity, and another feature is the cell nuclear molding and the cell-to-cell wrapping, which you see in the anaplastic. So if you see either this appearance or the large cell appearance, it comes under the large cell or anaplastic variant. Now, sometimes you see these kind of spindled areas with a lot of cytoplasm, with almost looking, can you see this long strap cell-like appearance? And you can demonstrate positivity for myogenin or desmin in this. And earlier these used to be called medullomyoblastomas, but now they're called medulloblastomas with myogenic differentiations. Sometimes you see black pigment, which is melanin, and those are called medulloblastomas with melanotic differentiation, but of no real significance in terms of, they're not subtypes at all. They're just some differentiation within the tumor. In terms of prognosis, the desmoplastic nodular is the one which has excellent prognosis, and the MEBENS, whereas the large cell anaplastic is a high risk. Now, I said the differentials are this ETMR and the ATRT. This is a embryonal tumor with multi-layered rosettes, a very hypercellular tumor. There's some necrosis here, but you can see within this, these rosette formations. And these tumors are positive for a marker called Lin28, and that is very specific to these tumors. So you can see here these rosettes staining with Lin28. So this is one of the differentials for the medulloblastoma. They will have a retained expression of INI1. Atypical teratoid rhabdoid can have these kind of poorly differentiated areas, but will also show areas which have rhabdoid appearance with abundant cytoplasm, vesicular nuclei like this. And if you see this, very good. If you don't, also one has to look for the mark. It's polyphenotypic, so you'll see SMA positivity, EMA positivity, focal GFAP positivity. But typically, they either show loss of INI1 or BRG1 in these tumors. So keep these two high-grade tumors in mind when you come across a medulloblastoma. Of course, medulloblastomas are the most frequent. So they're positive for synaptophysin typically, and the desmoplastic ones show synaptophysin within the nodules. The MIP is higher in the internodular zones, and P53 is done for further subtyping of the desmoplastic variant. All of them show retained expression of INI1 and BRG1, and they're Lin28 negative because they're not TMRs. So quickly, apart from the histological definition, they are also defined molecularly into the Wnt activated, the sonic hedgehog activated, which can either be wild type or P53 mutant, and the non-Wnt, non-SHH type. So this reflects a kind of biological heterogeneity which causes this classification. Again, on methylation profiling, they are now being further subgrouped. The sonic hedgehog has 4 subgroups and so on. But the non-Wnt, non-SHH has 8 subgroups, but we won't go into this. These are all correlate with prognosis in these tumors. So medulloblastomas, the most common is the non-Wnt, non-SHH, and the SHH activated, particularly the wild type, has a bimodal distribution, both in children and then in adults. And the one which is P53 mutant, the SHH with P53 mutant is very rare. So I already went into the location. I'll just say that these Wnt are predominantly classic, rarely can be a large cell type. The sonic hedgehog pathway ones, like we saw in our case, which was desmoplastic nodular mainly, and if it's P53 mutant, most of them are large cell anaplastic. And non-Wnt, non-SHH can be either classic or large cell anaplastic. So the markers, the surrogate markers that can be done for these tumors for differentiating are beta-catenin for the Wnt pathway, GAB and YAP are also done. So beta-catenin has to be nuclear positive for it to be called a Wnt pathway subtype, and along with it you see YAP1 positivity. For the sonic hedgehog, beta-catenin is negative. It occasionally shows cytoplasmic staining, but they will be positive for GAB and YAP. And this one will be negative for all. There are some newer markers like filament A and OTX2, which are also helpful. OTX2 is negative in SHH. In our lab, we don't have these markers. We just use these 3 markers at the moment. We've just about started using OTX2 because YAP1 can be a bit difficult to work with. So remember that for beta-catenin to be positive, it has to be a nuclear positivity. Cytoplasmic positivity does not imply a positive beta-catenin. So if you look at it, this nuclear positivity is what you need for beta-catenin to be positive. And GAB1, you have to see cytoplasmic positivity for GAB1. So in terms of outcome, the better outcome is for the p53 wild type SHH and the MIP, extensive nodularity and the desmoplastic nodular, which fall under this, have a good prognosis. There's no difference in older children and adults between the desmoplastic and the classic, but in the younger age group, it definitely has a better prognosis. So in this particular case that I gave you, the beta-catenin, Shatabdi, can you interpret this? This is the beta-catenin.
The beta-catenin are positive here.
Be careful. Cytoplasmic positivity. So therefore it is negative. That's what I was trying to tell you. When you see cytoplasmic positivity, do not, it's looking positive to you, but it's only the nuclei are all negative. Okay? Whereas the gap is showing in these internodular zones strong positivity for
Strong positivity.
gap.
And
Okay? So, in addition, we did P53. P53 was negative in most areas, a little bit of staining. P53 has to be diffuse and strong to be considered as P53 positive. Otherwise, it is considered as P53 wild type. YAP is a difficult stain, but when it works, it's really good. And here, this particular case was YAP1 positive. So, putting all these together, it is GAP positive and YAP positive, and so it comes under the SHH group, and it's P53 negative. So, our case would be a medulloblastoma, SHH activated, P53 wild type. So, the essential criteria for histological define, WHO only gives the essential criteria for classic, but if one is to apply it to desmoplastic, it has to be a medulloblastoma and should have essential features, probably the desmoplastic nodular appearance. This is only defined for the classic, where it says you have to have absence of this feature and retained expression of iron bar. Okay, so SHH activated P53 wild type have to essential is medulloblastoma, wild type P53, which you have to do with the PCR, and SHH pathway activation with the surrogate marker which we have, which is GAB and YAP, or with DNA methylation profiling. So in an integrated diagnosis, this would be, I'm sorry, I'm just going ahead with this. This is a desmoplastic nodular histologically defined CNS WHO grade 4. You can stop at that, or if you have the other markers, you can say it's SHH activated T53 wild type CNS grade 4. And say here that you've used surrogate markers for demonstrating the molecular subtyping. Okay? With that, I come to an end. Tejpal, neuroblastoma is a big deal in TME.
So I think as pathologists, we look forward to the histomorphological classification into the classic nodular desmoplastic MBAN and the LCA, but also now we need the molecular subgrouping information. And I think in India, still using the IHC platform, I think it is reasonable to use the IHC to arrive at a molecular subgrouping. Of course, if we have more advanced techniques like we do, 12 the differential expression of 12 protein coding genes, or use the nanostring or the methylation profile, which classifies them more accurately. The only downside of using IHC platform is that you can't differentiate between group 3 and group 4, so you have to leave it as a non-Wnt, non-SHH. But if you use more advanced platforms, then you can define group 3 and group 4 separately. Having said that, as Madam showed, now we understand that within SHH there are 4 subtypes, and within the non-Wnt, non-SHH there are 8 subtypes. So I think this just keeps on evolving as we learn more and more. But at least the broad molecular subgroups, and if you have the IHC platform, you can at least define Wnt, SHH, and non-Wnt, non-SHH. I am not so sure about the P53 wild type, we have hardly come across a diffuse P53 positivity. I don't know.
I've learned this, Tejpal, recently. I had a discussion with Vani because we are part of some other groups, and apparently, unless you have diffuse staining for P53, you should, because actually the mutant version is very rare.
Yeah, exactly. That's what I'm saying. I mean, we just don't come across this diffuse P53 positivity, and it's rare. Although the literature does describe that in 10% of SHH activated are TP53 mutant, but that's not our experience. We hardly get a very strong diffuse P53 positivity.
Yeah, I mean, I rushed through these the medullos because actually the focus was more on the gliomas. There's a lot more of pediatric tumors and a lot more. I think they have to have a separate session, if Sumit is there, of embryonal tumors to do justice to all the embryonal tumors. And but it's just so that the students can have an idea of when you see a tumor in a child, what one must think of. So, Kajri, can you show your presentation? I'll stop sharing.
Ma'am, do we have time for that? Should we go ahead? Should I go ahead?
How long will you take?
Hardly 5 to 6 minutes.
Yeah, I think it's important that.
Yeah, sure. Okay, ma'am, I'll show. Okay, so continuing from where I left off, so this was the point, the importance of the various sequences which we need to know. So just let us come to the diagnosis. So what we saw is this hyperintense tumor, as I told, something which is hyperintense is likely to be of a lower cellularity or therefore likely to be of a lower grade. And on the other hand, this is again a midline fourth ventricular tumor. However, it is a little bit hypointense, so therefore supposed to be of higher grade. So this is basically a pilocytic astrocytoma, and this is a medulloblastoma. Again, coming to the diffusion features, as I told, the lower grade tumor will not be diffusion restricting, as we can see here in this case. So pilocytic astrocytoma does not show diffusion restriction, whereas the medulloblastoma shows diffusion restriction. So therefore, it is bright on diffusion weighted imaging and dark on ADC. So therefore, it is showing diffusion restriction. Again, showing the importance of post contrast. So here we can see in the first case, it's intense homogeneous enhancement. So as madam showed in her slides, that pilocytic astrocytomas are known to have this intense macrovascular proliferation. This is the precise cause that there is intense homogeneous enhancement in the solid component of these tumors. Whereas in this medulloblastoma, we can see this heterogeneous enhancement. Actually, medulloblastomas are highly cellular tumors, so therefore they either show a very heterogeneous enhancement or a very slow enhancement because of the because of the intense cellularity of these tumors. So this was just how to differentiate on these three basic sequences for the pathology students, how to tell on imaging whether what we are looking at, if we are looking at something like this, a posterior fossa midline tumor which is present in the fourth ventricle, which could be either of these two. So just showing the last few examples, the same case, what we are seeing here is again a T2 hypointense tumor in the fourth ventricle, which has small cystic spaces, which shows diffusion restriction. So it's bright on DWI and dark on ADC, and it shows heterogeneous post-contrast enhancement. So basically, we know that it's dark on T2 and it's showing diffusion restriction. So we are looking at a high cellularity tumor. So this is basically a medulloblastoma. Whereas when we are looking at this particular case, if we look at more carefully, this is less hypointensity. So this is more bright. This is much more. This is showing less diffusion restriction. So this is less bright on DWI. And the type of enhancement, so not only the location and the signal characteristics, but the extension of the tumor. So if we look at this particular tumor, we can see this typical toothpaste or plastic kind of extension. It is extending along the foramen magnum. It is extending along the foramen of Lashka to involve the subarachnoid spaces. So this is an epentymoma. So these two slides are basically to show you how you differentiate from similar looking lesions on not only upon on the signal characteristics, but also the type of extension and type of the enhancement and diffusion weighted imaging features. So, as Madam told, we had discussed a lot about medulloblastoma, and medulloblastoma can be basically divided molecular classification into 4 subtypes, that is WNT, SHH, group 3, group 4, and that can be differentiated on imaging also. So, the first most common imaging of WNT type is this location in the CP angle cistern, and often it is associated with bleed. So, a medulloblastoma which is arising from the CP angle cistern is likely to be a WNT subtype, and often this presents with bleed. The one which is arising from the cerebellar hemispheres, the cerebellar hemispheric medulloblastomas are generally the SHH subtype medulloblastomas, whereas the group 3 and group 4, they generally are present as fourth ventricular masses. The difference between the group 3 and group 4 is basically the group 3 lesions generally enhance more vividly, whereas the group 4 lesions, they enhance much less, and they are generally located towards the lower part of the fourth ventricle, whereas the group 3 are located more on the upper part. So on the imaging also we can get a hint regarding what kind of a medulloblastoma we are looking at after we have decided on our mind that this is a high cellularity tumor and it's a high grade tumor, likely a medulloblastoma. In the contradistinction, the previous 2 tumors we saw, we can see this lesion which is again projecting into the fourth ventricle, but this has a cyst with a mural nodule kind of imaging finding. So we can see a hyperintense component, and because it is a hyperintense solid component, we know it's a low cellularity tumor with a rim of cystic change. The solid component does not show diffusion restriction, so it's dark on DWIN, bright on ATC, and it shows intense post-contrast enhancement. So whenever we are looking at a tumor which has this intense solid enhancing component in a pediatric age group, we should very definitely think about the pilocytic astrocytoma, especially when the location is like this. So this actually is a medullary pilocytic astrocytoma which is projecting to the fourth ventricle, but it has a typical cyst with mural nodule morphology. So apart from this cyst with mural nodule morphology, we have this solid enhancing morphology, which Madam also showed in the first case. So this is a suprasellar or an opticochiasmatic pilocytic astrocytoma, which has this typical T2 hyperintense signal, and it will not be restricting in diffusion weighted imaging, and it shows intense homogeneous post-contrast enhancement. And lastly, finally showing you the more malignant one, that is the diffuse midline glioma H3K27, a mutant or as Madam told, altered. So basically this as if we look back at the pilocytic astrocytoma, we can see that how heterogeneous and how dark this tumor is on T2 weighted imaging. And if you look at these areas which are more darker, these are actually the areas of bleeds. So as I have not explained in this particular presentation, for pediatric age group, I think we should, for any age group in fact, for any kind of brain tumor, there are other sequences like radiant and SWI which play a very important role in telling us whether there are calcifications within the tumor or bleeds within the tumor. So this particular sequence, that is the SWI, it shows that there are a lot of bleeds within the tumor. There is a lot of diffusion restriction, and obviously we can see this is actually an advanced imaging which is basically a perfusion weighted imaging, and this blue areas are showing low perfusion, and we can see these green and red areas, they are showing extremely high perfusion. So this is a very high grade tumor, and therefore so this is again located in the midline. It is located in the corpus callosum splenium. Generally we see it in the thalamus and brainstem, that is pons, but obviously this can be seen in this location also. The midline lesion, we can see the supratentorial midline lesion which features a very high grade tumor. So not all diffuse midline gliomas will look like this, because they can often look very indolent, and often they are generally diagnosed with the specific mutation only. But this particular example I showed to just show you that what a high grade tumor exactly looks like, in contradistinction to the pilocytic astrocytomas which I showed. So, and also you can see that the enhancement is also very heterogeneous in this case. So in as we saw in the pilocytic astrocytoma, it was intensely enhancing the solid component. This one is showing a very heterogeneous and necrotic kind of post-contrast enhancement. So with that, I'll end my presentation. I think this was just to give a basic idea regarding what the different kind of brain tumors look like. Ma'am, over to you again. Thank you so much.
We are done. Are there any questions or anything that we need to?
think all of us deserve a dinner. So
Thank you so much, ma'am, for walking us through these cases and teaching us